Good morning, ladies and gentlemen. It's a pleasure to have every one of us on this call this morning. The University of Benin Teaching Hospital staff webinar, the first of its kind in the history of this hospital, and I can assure you in any hospital at all for that matter in the country, Nigeria. It's our pleasure to present this webinar today, which is also a creative invention and the thinking or a product of the thoughts of the minds of our highly esteemed Chief Medical Director, Professor Darlington Obaseki, who is the chief host of this webinar. He's on this call this morning. Mr. CMD, you're welcome, sir. Yeah, we appreciate you. Ladies and gentlemen, we want to appreciate every one of us that has made that time to join us on this call this morning, for your time and even for your resources. So many persons have been complaining about the issues of data, but for you to have joined this call using your data, we appreciate you for doing that. And it's important to let us know that the essence of this call is to bring every staff of the hospital up to speed with regards to what the management of this hospital has been doing since the entire world became bedeviled with this evil pandemic. They call it the COVID-19. That's taken over, the social space, the science world, the economic world, and everything was almost grounded. But thanks to the Almighty God that has given wisdom to scientists, we are able to maneuver, the various labyrinths and the various obstacles. And by the grace of God, the specialist team of professionals in UBTH, we are able to adequately manage this pandemic. And so it is a kudos to these hospitals, a kudos to management for what they have been able to do in this regard. And so many things have happened. A lot has happened that this management has done. And so it is time that management feels that every staff of the hospital should actually know what we have done in this regard. And therefore, on this call today, which is the first of the series that we're going to have, we're going to have some 5 lectures or seminars, if you wish to call it that. And then it's my pleasure to just introduce the panelists that will be on this call. And of course, before we do that, we want to recognize and acknowledge the presence of this call on all management staff. The Chief Medical Director is here already, the Director of Administration, the CMAC, Director of Administration, Mr. Emojimo Kadiri, the CMAC, Professor Mwemu. We acknowledge the Deputy Chairman Medical Advisory Committee in charge of clinical matters, Professor Obehi Akoria. We recognize the DCMAC Training and Monitoring, Dr. Stanley Okubo. We also acknowledge the presence of the DCMAC Ethics, Research and Ethics, Professor Mokwa Adeleye, the DDNS, Mrs. Doris Asama, recognize you, the Coordinator of Dental Complex, Dr. Louis Ibawo. We recognize you as well, and we appreciate every one of you for the effort that you have put in place to ensure that this call is possible today. Then quickly, let me introduce the panelists that will be giving us the information that we need, this morning. Of course, immediately after this introduction, the Chief Medical Director will come on to give us his own lecture, the Professor Darlington Obaseki. It's a man whom we love, a man whom we are very proud of, always coming out with cutting-edge ideas and incisive ideas that always bring solution to rather difficult and challenging circumstances. And also after that, we have the CMAC of the hospital, Professor Casimir Omwemo, is going to be giving us a talk on clinical management of COVID-19 UBTH together with the face of our isolation center, Dr. Ben Okwara. They are here on the call already. We also have Dr. Stanley Okubo, the DCMAC in charge training and monitoring. He will also be giving us a talk on keeping the hospital running, logistics and supply chain management. And we will also have Dr. Mrs. Ogogodo, who happens to be the chairperson of the Infections Control Committee. She'll be giving us a talk on infection prevention and control and surveillance activities in UBTH during the COVID-19 pandemic. Then last but not the least, among the panelists, we have Dr. Greg Okwobo, situation analysis in Nigeria, in Edo State, and in UBTH. Interesting to let you know that Dr. Kwobo will not be speaking from here in Nigeria. He's going to be speaking from outside the shores of this country. And so we thank God for science that's made all that possible. So once again, ladies and gentlemen, we welcome you all to this call. I especially want to acknowledge all those who are participating from the various viewing centers that management has set up. Wherever you are watching and following us on this call, we want to appreciate you. For those who are at the Human Resources Seminar Room, we appreciate you. Those who are at the VIP Lounge, we have some at the Nurses House. We have other persons at the Oba Kenzwa Hall, upstairs and downstairs. They're there. I also have information that we have people streaming and following us from the GPC Clinic, Pathology Seminar Room, Ophthalmology Seminar Room, and all the seminar rooms, that has been made available for everyone to follow us. We appreciate you for your time. And just some quick information for us to take note as we go along. If you check your screen, I'm sure you already see a poll, a survey poll that's already there. I want you to just tick in those boxes what you think and submit. And that shows your participation and whether you appreciate this call. Then two, we want to inform you that you have opportunities to send in your questions. But all you need to do, if you are at the various viewing centers, all you need to do is to get a piece of paper, scribble down your question, pass it on to the ICT personnel that is there, and they will, send the questions to us. And by the grace of God, we'll be able to give adequate response to your questions. And two, again, we are reminding us, beyond this poll, we're also going to have 2 other polls or survey after now. We encourage you to at least click your option and submit. Okay, so as much as possible, we'll try to make this call not too long. We appreciate your time, and we know people have a lot of things they need to do. And ladies and gentlemen, I also quickly want to appreciate, I don't know if he's already on the call, the DG of the NCDC, who has promised to join us on this call. We appreciate your presence, or if it's a rep, whoever it is that has joined, we appreciate you, as well as every other person that we may have invited and has been able to find time to join us on this call. So I say thank you, and I welcome you all to this presentation. So it's my pleasure right now to invite to take the call the Chief Medical Director of this hospital. Wherever you are, if you have your phones, there are icons there and you can show that you appreciate this man with a clap. And so my pleasure to introduce and welcome to the call the Chief Medical Director, Professor Darlington Obaseki. CMD, sir.
Yeah, thank you, Head of Public Relations, Joshua Wala. Let me welcome all of you. And for the sake of time, I will go straight to the meat of the presentation. I hope you can all see my screen. This morning, we are going to be talking, I'm going to give an overview of COVID-19 UBTH. This idea came to us, wanted to talk to our staff about all we've been doing. PRO, please mute your mic. All we've been doing about COVID-19 for the past 3 months in UBTH. But along the line, we also crossed our mind that so many other institutions, hospitals across the country, especially in this area. Later. This area would also share the same challenges that we've, and so we felt we should share experiences and let's see what people, other institutions can learn from us. Before we go on, let's talk about the ground rules. Please, everybody should mute their mic. Though we have a second layer of protection for that, our head of ICT will do so if you didn't mute yours. Please mute your mic. So everybody mute your mic. ICT, please be active about that. Don't feel offended if you mute your mic from here. We do so. Second rule, ground rule, we won't be taking questions other than written comments and questions to the chat group. Because of time, there's a lot to talk about and we have a lot of things to share. So because of time, if you have questions and comments, just type it in the chat and we will answer you at the allotted time. My presentation, which is an overview of COVID-19 in UBTH, will be taken with this outline. We use the word storm because it was a storm we were expecting to make a landfall in Nigeria and in Edo State and UBTH. we talked about early response, collaborations, and the rest you can see on the screen. The background we all know, COVID-19 came into consciousness sometime in 2019, December, starting from Wuhan in China. Our first case in Edo State was in March 27, 2020. And our index cases in UBTH was on March 31st, and it was 2 cases at the same time that were diagnosed in UBTH. How did we prepare for the storm? We knew here in UBTH that this was coming. We knew a storm was brewing. We knew the storm was ravaging the whole world, starting in China, Asia, Europe, and the Americas. And we knew it was just going to be a question of time that it lands here. So we just had to prepare, and we did that by first monitoring global events, looking at the epidemiology of the virus as it affects other systems, other countries, the biology, the spread, and all the other factors, the pathophysiology, and all the literature that was coming out. We're monitoring it and waiting for how best we can use such information to prepare. But before then, UBTH had focused on, for the past 3 years of this management being in existence, on quality healthcare. In particular, the domain of quality that emphasizes patient safety. Patient safety in the hospital simply means that people should not be harmed in the process of seeking care from our hospital. So we emphasize that, especially in regard to what we call nosocomial infections or hospital-acquired infection. And we have been doing all we can to minimize or prevent the spread of such infections in the hospital setting. That preparation before the era of COVID gave us a base to prepare for this storm. We also had in UBTH some things that we can say is a given, but the country we live in, not really that so. Running water is at all service points, has always been there for a long time. We make sure we liberal supply of liquid soap to all service points and all taps in UBTH. Gloves and other consumables have never been an issue since we came on board. We also strengthened our infection prevention and control committee. We reconstituted it, and they have been very active in training of our hospital staff on infection prevention and control measures. But we had initial challenges when COVID-19 eventually came to Edo State, to Nigeria. In UBTH, we didn't have a purpose-built isolation ward for treating infectious diseases up till February, March this year. We had no diagnostic capacity. We couldn't diagnose the SARS-CoV-2 virus or even Lassa fever that have been ravaging Nigeria for up to 12 years. We could not, UBTH was not a diagnosis center for Lassa fever or even not talk of SARS-CoV-2. And of course, consequent on that, we have not built human capacity in managing infectious diseases over the years. We have not done so because for Lassa fever and other infectious diseases, like especially viral hemorrhagic fever, when up to very recently, when we have cases like this, we just refer to a specialty teaching hospital. And that undermines our ability to build capacity and be at home managing such cases. So these were initial challenges that we had to confront. But our early response, when eventually it came, or just before we had our first cases in Edo State, we set up a clinical governance framework for COVID-19. We set it up here in UBTH, and they made up of different pillars, including case management pillar, diagnostic pillar, headed by Dr. Sagbovo, Dr. Mrs. Riyad Mosio Sagbovo, the case management pillar, risk communication pillar, logistics and supply chain pillar, and others, including screening, triaging, and monitoring pillar, headed by our head of nursing, and a central coordination and research pillar that I personally handled. So these pillars eventually develop strategies, governance strategies, tools, protocols, and guidelines, and advisories that we have used in tackling this virus the past 3 months, and we meet like twice to thrice every week virtually. Along the line, we've also developed indigenous expertise and technology, which we have deployed. I'll talk a little bit on this later on. We've also restructured our workforce, distributed them, and reorganized our workforce to support the fight against COVID-19. But we must here at this juncture mention the immense support given by our board of management, headed by Bashudun Doja Adewolu, who in the last board meeting sometime in March gave us a blank check to do all we can to make sure that we protect our staff and tackle this virus. I mentioned indigenous expertise and technology that we've deployed thus far. We've had to go back to our local technology and try to get things that, because resources are lean, especially in these times, price of everything we're going up, we need to use what we've produced. Alcohol-based hand sanitizers, we've started producing that like almost a year now. But during this fight against COVID, we realized that we needed to protect our staff, and we started mass production of alcohol-based hand sanitizers, which we distributed to almost every single staff in UBTH free of charge in a small 30 ml bottle. We also supplied to all service points to use liberally. The picture you are seeing there is a picture of a hand wash station that we locally produce. We produced about 30 something of this hand wash station from these drums that we now connect to our mains. Our logistic man will talk a little bit more on this. And these drums, with this hand wash station, we station across entrances to all our service points, clinical service points, both entrance to the hospital and exit from the hospital, so that people can, with liquid soap that was provided, as you can see there, so people wash their hands as frequently as they wish. You don't need to refill it. The tap is connected to our water mains and it drains autonomously. We also have produced, we are now producing reusable gowns, face masks, face sheets, eye goggles locally here with UBTH. And also, like we see and we saw in different parts of the world, even in better healthcare systems of Europe, where they ran out of all these things, we knew we have to find a way to reuse some of these things and to produce them. So we apart from just producing, we also devised a ultraviolet light sterilizing unit that we use to sterilize some of our face sheets and goggles. I will show you one now, something like this. This is an oven that was spoiled that we now reconfigured to a UVC sterilizing unit, ultraviolet sterilizing unit that you can see here. And this ultraviolet light, we got ultraviolet bulbs and we validated it by doing microbiological testing on the things there. Our early response also involved workforce planning and reorganization. We did a risk assessment, stratification, and deployment of staff. By that, I mean that we, following what was going on in Europe and Asia, we knew those who were vulnerable to dying from the disease, and mostly a certain category of persons, elderly persons, and those with some pre-morbid conditions like hypertension, diabetes, and chronic lung diseases. So what we first of all did was that we realized that we needed to protect our staff, and first we said we cannot legislate that no staff will become infected, but we can do all we can within our power to make sure that nobody dies from it in UBTH. So we sent out questionnaire assessment forms and ask our staff to volunteer if they have any of these pre-morbid conditions, any of these conditions, hypertension, diabetes, with evidence. And those that have, we put them out from the front line, from direct patient contact, and distributed them to other work areas. At the last count, we had about 80-something staff who were in this category, and some of our elderly staff, we also took them out from the front line to protect them. We also employed about 33 paramedics from our training school, just graduated on a local basis. They helped us tremendously in screening and triaging at our clinics and our wards. And we adapted our work schedule to enforce social distancing. After today, these are the service areas for COVID-19 care in UBTH. We have an 8-bed sub-isolation ward. We have repurposed and redesigned our emergency room to become a 24-bedded isolation room, which you are seeing here. This is a clean corridor you're looking at, and these are the wards. There are patients right there inside. It's a very comfortable place. Everybody has been treated here, they have attested to that. We also have an 11-bed holding ward. This holding ward is for patients that will flag off before test result comes out. As patients come to UBTH, I know quite a number of them, we don't know if it's COVID positive or not. We test them. Before results come out, we put them, if the ones we think are likely going to be COVID positive, put them in an isolation, in a holding bay. We also have a 2-bedded ICU. And in addition, an 18-bed annex with self-contained rooms for those that, we also call it a transit ward, for those that are now well or not too sick, they go there on the way out of the hospital. All of this would not be possible without these incredible persons. I'm sure a few of them, which I will show. There are so many of them, I can't show everybody. We call them our COVID champions. Led by this, I'll call it Superman. Dr. Benson Okwara is a Superman. He volunteered, the first person to volunteer. He's a dermatologist, it's not an infectious disease expert initially, but he is now. He led a team, he has led a team of volunteers that have volunteers here and that have been fighting this battle for the past 3 months. Also, I must mention the head of nursing. This is incredible because he's the head chairman of the Nigerian Association of Nigerian Nurses and Midwives. Together with his secretary, they volunteered and they have been working in isolation ward ever since. There are other persons, I cannot mention all of them, but Dr. Esra Bodo, head of IPC, our senior chief president of family medicine, Dr. Duwari, all these are all volunteers. Of course, the man in the middle, our staff of the month for the month of May, Mr. Isaac Ibaruma, who has done a fantastic job, almost single-handedly helping us set up a molecular diagnostic lab that we are now doing more than 50% of the testing capacity of Edo State in our lab in just a short time, less than 2 months. We've also had collaborations with different bodies and institutions. The Center for Excellence in Reproductive Health Innovation, led by Professor Konofwa in Uniben, I will talk a little bit on them. Edo State government, I cannot praise the executive governor who is in this picture in front of our molecular lab when he came enough for the support, unwavering support he has given to this institution ever since we started. NCDC, led by Dr. Chikwe Yekwaza, he was here 2 weeks ago, and he has always been, his phone has been open to me. He promised to join this call shortly, or if he cannot make it, he will send a representative. When he comes, he will give us a word. Professor Okokbeni led ISTH. They've also been very cooperative, and we have worked together. They are one of our collaborators. And corporate entities, in particular, this Chinese company that makes steel along the bypass, Yongxing, they've donated huge amount of PPEs and other consumables to us. But for Edo State government, like I said, the government of Edo State, they've supported almost everything we've done. You can see here, they helped us repurpose our 8-bed temporary isolation facility. The 24-bedded isolation ward, our former medical emergency room, they did it for us. They've donated 2 ventilators, PCR reagent, other consumables, and laptops. And also, the governor himself personally called Dr. Chikwe Yekwaza to help us with fast-track our accreditation for COVID testing, which we're now doing in UBTH. Sorry. Professor Konofwa and Seri, that's the Center for Reproductive Health Innovation, we did an MOU with them. This one, we're signing the MOU sometime in February, I think, or March. When we sign the MOU, we don't have, as of today, we still don't have a PCR machine, but Seri has one, and he gladly gave it to us, leased it to us rather. That's the PCR machine, the MIC PCR machine, and we are using it today. That was given to us, lent to us by Professor Konofwa. And apart from that, they've also provided logistic support. Whenever we run out of consumables, they do give us some of their consumables here. And we are currently in very close partnership, doing a research collaboration with SERI. There's a proposal right now trying to validate some test kits that both NUC will fund. We have reached last stage together with SERI. I mentioned this before. Dr. Chikwe was here sometime about 2 weeks ago, right this in our isolation facility when he came. And if they've helped fast track our accreditation and validation of our PCR lab and testing, which we are doing now, and support, together with ISTH ILWA, support our training of our staff for PCR testing. But also, we have also provided technical support to the Edo State COVID-19 response team in epidemiology modeling, policy formulation, and research. UBTH has been very active in providing top-class human resources, human capacity for the response of the Edo State. So many of the things they have been doing and been supported by us also. Now, what's the current status of COVID-19 UBTH? As of today, we have done about 3,742 tests in our molecular lab for COVID, SARS-CoV-2, I mean. That is more than about 52% of total number tested in Edo State currently, out of which about 543 are positive, again, about 50-something% of the total positive in the state. But for UBTH samples, out of the 543 positive, 163 are from UBTH staff and patients. As of today in UBTH, out of the 163 that are positive, we have 50 active cases that are under management at UBTH. We have discharged 77 out of the 163, and we've had 36 mortalities. Unfortunately, we've had 43 of our healthcare workers who have been infected, including 26 doctors, 6 nurses, 3 paramedics, and the rest you can see. But we've also discharged about 28 of them. So the active number is about 18 right now. COVID-19 has impacted tremendously on our normal clinical services in UBTH. This chart, as you can see, this is our outpatient attendance for 2019. You can see we do about 26,000 in March and April last year. But this year, 2020, this bar here, the blue bar, for March this year, 27,000 still, we are going up. But with the first case of COVID-19 UBTH, 1st of April, you can see that we had a 60% drop in attendance, in outpatient attendance to 10,582. Same thing with our inpatient admissions. You can see the drop, about 50% drop. We had about 2,000 patients admitted in the month of March 2020. This dropped to about by 40% or so to 1,351. Current challenges, the same challenges that we have is what most hospitals are dealing with across the country, across the world, in fact. Because COVID-19 does not mean that all other diseases have disappeared. We still have treating other infectious diseases, cardiovascular diseases, cancers, and the rest. They are still there. So maintaining the dual track of health services, maintaining services for these diseases, while at the same time tackling the problem of COVID-19 is a big challenge, not just here, across the world. We also have to deal with the challenge of healthcare worker burnout and diminishing morale. Keeping morale up is a challenge. Of course, like I said earlier, we have about a lot of our healthcare workers who are infected. We need more PPEs, more consumables, but more importantly, or most importantly, what people don't talk about is reducing cash flow and increasing overhead of hospitals. We keep hearing about palliative. Nobody has mentioned palliative to the public hospitals in terms of cash injections for them to cope with the COVID-19 economic impact on hospitals. I just showed you our graphs, our charts. We make money from patient care. That has dropped by more than 60% of our revenues. And meanwhile, the overheads are increasing because these consumables are a pack of gloves of face mask was about 600, 700 naira before COVID-19. It's about 18,000 naira now. Yet we cannot pass this cost, this added cost to our patient. Of course, risk communication and adherence to IPC has also been a challenge. So many persons refuse to obey some of these instructions about social distancing and use of face mask. But all in all, what has helped us? One is a highly motivated, self-sacrificing workforce. I mentioned some of them. This goes across the whole hospital, not just the ones I mentioned. Our prior emphasis on quality healthcare, our appropriate use of technology. We started a virtual clinic where some of our patients and some of our doctors can come. You don't have to come to hospital if you don't need to. So we consult online if you have to, but only those that really have to come can come. And we've also taken decisions based on best evidence. Summary and next step. COVID-19 has come with challenges, but we have worked as a team and with other partners to confront these challenges. We all have to devise ingenious ways to live with this disease. This virus is not going away anytime soon. This pandemic is not going away anytime soon until, I believe, personally, until a vaccine comes up, which probably will be sometime next year at best. We just have to find a way to live with it. And of course, we need more resources to do this. Acknowledgement, let me thank the board of management of UBTH, the management team, my team, fantastic. They said I pushed them hard, but we all have to be at our best to confront this disease. The rapid response I've already mentioned, all UBTH staff, but in particular, let me mention our unions. I've already mentioned the Nursing Association, NAM, UBTH, Association of Resident Doctors, fantastic support, Medical and Dental Consultant Association of Nigeria, leadership also be very supportive and every other union UBTH. Thank you.
All right, thank you very much, Mr. CMD. That was a beautiful presentation by our able Chief Medical Director, and if only we could see other listeners and other people who are watching from the various centers, I'm very sure now a round of applause would be very good to give to the CMD for how much the management team has done in the management of this pandemic. But quickly, I just want to say this, that there's something about leadership that the great man once said, General George Casey. He said that clarity and simplicity are the antidotes to complexity and uncertainty. You know, when the pandemic came and there was a whole lot of confusion everywhere, the Chief Medical Director and his team, simple structure, simple systems, you know, they have been able to bring all these within a manageable proportion in the hospital. So, Mr. Sembi, kudos to you and to your team. And of course, we have also appreciated the staff of the hospital. I also want to say big ups to all our colleagues in the various professions, and encourage us too that we should not allow our morale to diminish or to be dampened. Let's just keep up the fight, and very soon we'll be able to shout Uhuru. Thank you very much, Mr. CMD. All right, next presentation we will listen to is from Dr. Greg Okwobo. Dr. Greg will be speaking to us on situation analysis, Nigeria, Edo State, and the UBTH experience. Ladies and gentlemen, Dr. Greg is going to be speaking to us from outside the shores of this country. Dr. Greg, you're looking fresh this morning. Take on the call, sir.
Thank you very much, the PRO of UBTH. I want to say very warm and cold at the same time good morning from where I am. Thank you, Mr. Joshua Weiler. And I want to say a big thank you to the CMD for this opportunity to be part of this, and to everyone that is hooked up to this presentation right now. My task today is to help us go through the journey of the evolution of COVID-19, both globally and locally. So I'm going to use this outline to look at how we have fared, what is the current situation globally, in Africa, in Nigeria, in Edo State, and in UBTH. But before I go on, I would like to go through what is COVID-19 and quickly run through the epidemiology of COVID-19. Well, COVID-19 is a disease caused by a new virus called SARS-CoV-2. To the best of evidence, the virus originated from Wuhan in China. On the 11th of March 2020, the WHO characterized the spread of COVID-19 as a pandemic, which means the whole world is now being affected and there are intercontinental and inter-country efforts to control it. Let's quickly run through the epidemiology of COVID-19 because I believe this is important so that we can situate the virus where it belongs. COVID-19 is actually an RNA virus, and it belongs to the beta group of the corona family of viruses. There are actually 4 groups of the coronavirus family. Beta group is the one that COVID-19 is answering a surname to. There are 7 other coronaviruses that infect man. So SARS-CoV-2 is just one of them. This is the shape, and it has a characteristic envelope, which we all see each time the picture of COVID-19 is presented to us. But most importantly is for us to be aware of how small this virus is. It's just between 100 to 160 nanometers in diameter. And this is very instructive when it comes to our face mask and the type as well as the profile of the face mask with respect to controlling it. Transmission. It has been shown that the COVID-19 virus jumped from animal to human. This is still being investigated. There is not much evidence to substantiate that, but this has been followed up closely. Like I said, there's so much we don't know about COVID-19, even as of today. So information is evolving every day. But what is known is that there is human-to-human transmission. The incubation period for COVID-19 is 2 to 14 days. If you compare that with the other members of its family, you realize that it has a very long incubation period compared to the other members of the family, which means if you are infected, it can take a minimum of 2 to a maximum of 14 days for that individual to manifest infection, symptoms, and probably signs. The route of transmission is respiratory droplets, sneezing, coughing, even simple talking. Then we also know that it can be spread through contact and through fomites, surfaces, and so on. So if it's on any surface and you touch your face, then it can be transmitted. Then there are procedures that aerosolize these droplets. Such procedures too can lead to transmission. Evidence are already showing that mother-to-child transmission has been established or is possible. And but what is very, very important to us as healthcare workers is nosocomial transmission. If you look at this diagram right now, within the hospital setting, transmission has been very aggressive. So a patient admitted to the hospital can either give it to the community or can give to other patients. And it can also give it to visitors. And visitors can pick from the patient and take it back to the community. But most damaging is the patient also giving it to our beloved healthcare personnel. And this is where the whole transmission malady is displayed. So nosocomial transmission is one of the key issues that the whole world is following right now. Fecal-oral transmission has also been established, but much evidence has not laid more validity to that claim. Clinical features. Most people who are infected are asymptomatic, as much as 40 to 80% of the cases, while few people have mild infection, but while some, about 15%, 5 to 15% come down occasionally with very serious infection. We already know the symptoms that they may present with: fever and cough, shortness of breath, and so on. Added to that list is loss of taste and even loss of smell. And there are people who we know are very at risk, especially those who are immunocompromised, people with cardiopulmonary illnesses, our elderly people, and then the young and tender children that we take care of. Diagnosis is through our real-time reverse transcription polymerase chain reaction technique, and also a thorough patient history. Treatment is largely supportive, but there are candidate drugs that are being put forward today. And also, but there are so much issue about hydroxychloroquine, which has gone back and forth, and evidences are still a lot of research is ongoing to justify the use. But in UBTH, we still use it, but under a clinical setting, a clinical trial protocol. There are other means that this COVID-19 disease is being managed currently. However, I must stress that no vaccine has been established yet. And from my own angle here, where I am functioning right now, we may not even have that even in the first or second quarter of next year. Prevention. Prevention has been largely focused on hand hygiene, with simultaneous avoidance of touching the face. Respiratory hygiene is also key there. Utilizing PPEs, I cannot stress this enough. Other presenters will stress these other aspects. Disinfecting surfaces and objects, and limiting social contacts. So let's take a good look at COVID-19 in terms of the globe. And one thing that will quickly tell, as at 30th of June, there are about 10,500,000 cases worldwide, with 510 deaths, and about 5.7 million who have recovered. And if you look at this map, it is clear that almost every part of the world has been affected. 213 countries are reporting cases as at 30th of June. The top 10 countries affected are the United States, Brazil, and Russia. Those are the top 3. If you look closely at this list, you quickly notice that no African country is in the top 10, and we hope it remains that way. In Africa, COVID-19, the first case of COVID-19 in sub-Saharan Africa was actually confirmed on the 27th of February, sadly, in our dear country, Nigeria. And this is actually the third case in Africa, but the first in sub-Saharan Africa. And as of 30th June, we already have close to 400,000 confirmed cases, making up about 4% of the global burden. We already have almost 10,000 deaths, which is about 2% of the global deaths. About 200,000 have recovered, and 57 countries in Africa were reporting cases. And I must also stress that the first confirmed case was an imported case. So these are the top 10 countries in Africa by the share of total confirmed case. The epicenter seems to be South Africa right now. Our beloved country is number 3, and our dear neighbor to the right, Ghana, is number 4, while Cameroon, our dear neighbor to the right, is number 6. And from this graph, you also notice quickly that the cases are not abating, they are still rising. We've not achieved any peak case. And this Nigeria here, we are rising, but we're not rising as much as South Africa and Egypt. So what is the situation in Nigeria? The first case, like I mentioned earlier, was on the 27th of February, and the first death, sadly, was on the 23rd of March. As at 1st July in Nigeria, we have 26,484 confirmed cases, discharged well over 10,000. Sadly, we've had 603 deaths. And the cases in Nigeria from this graph still rising. We've not achieved our peak yet. And if you look at this table, what this table is trying to demonstrate is how often the cases are doubling per month. By the time we have the first case, within a month, it has doubled to 65. Within the second month of April, it has doubled to 1,300. Within the third month, we're already having 8,000. And within the fourth month, the fifth month, which is June, it has also tripled again to 24,000. It tells you the exponential function nature of COVID-19. And the death also is in that trajectory. Even though our case fatality rate seems to be stable at a point and now is decreasing, which means at least we are discharging more than people are dying from the health facilities. But the exponential nature of this disease is a cause for concern. And if you also look at, in terms of the spread of the cases, the age group 31 to 40 years have been most affected, which is, are the working and the health, it's supposed to be the working class of people in our country. Male somehow seems to be disproportionately affected. I don't know what's happening to our men, but 66% of the cases we are having are from the men folks. And then we also notice that unknown exposure or community contact, if I may say, is responsible for 73%. Just 2% are being imported as at today. The rest majorly is from community transmission. All states in Nigeria are reporting cases except Cross River State. It's either they are doing something wonderful, a miracle is going on there, or they are deliberately not reporting cases. However, every other case in the country, every other state in the country, they are making reports of cases. And these are the top 10 states in Nigeria that are reporting cases as of today. Our dear state, Edo, is number 5 with a total of 1,165 cases. However, more than about half of cases in Nigeria is coming from Lagos State, which makes it the epicenter of COVID-19 currently in Nigeria. Now, if you now look at our dear state, Edo State, the first case was on the 22nd of March, and the first death, sadly, was on the 31st of March. As of today, I've already said we have 1,165 cases. We've been able to discharge 418, and we've had 40 deaths. Cases are still rising, as shown in this graph. Daily number of cases are still rising in Edo State. And if you still look at Edo State, with the way we looked at that of Nigeria, you already notice quickly the exponential nature of the increase, and with respect to deaths also, and the case fatality rates. So we are not out of the danger zone yet. And June, from this table, seems to be the most deadliest month so far, as almost half of the cases we lost occurred in June in Edo State. 16 local government areas are reporting cases in Edo State, but 71% is coming from just 4 local governments: Oredo, which is from this graph is the epicenter. You can see it's almost like a majority of the cases, Ikpobaoka, Ego, and Ovia Northeast. And if you follow up with the geography, it will quickly dawn on us that our dear institution, UBTH, is sandwiched between Ego and Ovia Northeast. So we are also within the spotlight and the epicenter in our state. UBTH COVID-19 incident team actually in March made an epidemiologic projection for Edo State, which actually became the game changer in the way we view COVID-19 and in the way we prophesy about COVID-19. And this epidemiologic projection actually shows that by 28th of June, we're supposed to have a peak in terms of the number of admissions, and then it will now drop over time. So we are expecting that COVID-19 should have peaked in Edo State as at the 28th of June, going by this epidemiological projection, which the University of Benin incident team developed for Edo State government. But sadly, this has not been the picture. If you notice in these new projections made in June, the peak date has moved by 2 weeks. And the reason for this shift has been the collapse of our social distancing measures. People are no longer complying. There is now increase in political and religious events. COVID-19 cases refusing to be treated in healthcare facilities, and the overall complacency on the part of our citizens with respect to COVID-19. What is the situation in UBTH? How have we fared? Our first case and first death occurred on the 31st of March in UBTH. As at 1st of July, we have 163 cases, 71 discharged, and sadly 36 deaths. If you look at this closely, in terms of the confirmed cases, we have 104 males and 45 females. The deaths, 28 males and 8 females. Active cases, 35 males and 15 females. Then we discharged 37 males and 33 cases. With respect to healthcare workers, which is very important for all of us listening, infected in Edo State as at the 1st of July is 142 healthcare workers. Infected in UBTH is 43. And if you take that as a percentage of the total infected in Edo State, that's 30%. So 30% of the healthcare workers infected in Edo State are from UBTH. Discharge in UBTH, that's the infected healthcare workers, is 26, which is huge. This is more than this is about 60% of those who have been infected have been discharged. And gladly and graciously, we've had no deaths of any staff or healthcare worker in UBTH. So in summary, UBTH has a capacity to provide testing. Our DSCMD has already hammered on this. And we have also identified 543 cases in the state from our laboratory out of a total of 3,742 tests that we've done. We are actively involved in Edo State response to COVID-19. And most importantly, we are proactive in taking care of our staff. And that is why we have made a risk stratification for staff in all departments and units so that we can begin to handle each department and unit based on risk stratification and use that to make projections. So in conclusion, I want to say to everyone listening that COVID-19 is a disease caused by a new virus. Globally and in Nigeria, cases are rising. And our understanding of COVID-19 is changing extremely rapidly. And new findings come out daily. Combating COVID-19 effectively will require multiple steps, including social isolating and hand washing. And the development of effective drug treatment and vaccine is already a priority, and rapid progress have been made. So at this point, I want to say thank you all for listening. And I want to believe that we will remain safe and also as healthcare workers provide our best in the front lines. Thank you very much for listening.
Oh, thank you very much, Dr. Greg, for that beautiful presentation. We appreciate you for that. And please, wherever you are, just appreciate Dr. Greg for that wonderful presentation. Thank you very much. The next lecture we'll listen to will be from the CMAC on clinical management of COVID-19, UBTH. But before then, we'll just have time to take some few comments and questions. We also want to encourage us to please, from wherever we are viewing or watching from, if you have a question, please get a piece of paper, write down your question, send it to the IT personnel on ground, and they will, type in the questions for us to attend to. And also, as the surveys, they pop up, we encourage you to also participate in those surveys so that we can have a very good feedback. To take the comments and the question, we'll call on our Chief Medical Director, Professor Obaseki, to please quickly respond or direct someone to respond to this question. Same this side.
Yeah, thank you, Head of Public Relations. We've had very few questions, thankfully. That means that everybody's coming along. The few questions, the one that is most pertinent for me is to Dr. Kwobo. Somebody asked that I should clarify the transmission from asymptomatic people. Should clarify transmission from. Another person asked, have there been any death of healthcare worker in the state? I don't think I'm not aware about that, but Greg, you can help me out with that.
Thank you very much, sir.
That question, let me answer my own. Of course, as usual, it's about money. The pattern of hazard allowance as officers and interns and corpers are yet to receive in UBTH. Why? Well, the hazard allowance is from the federal government. Currently, they are paying those that are on the IP's platform. After we've contacted them in Abuja, and they said after they finish with IPs, those workers on the GIFMIS platform, under which interns and house officers fall under, will be attended to. This is nationwide, not just UBTH. Thank you. Then lastly, somebody said, we slides sent to email. I think we will do that because I think we register with email. So we'll try and do that. Then, Greg, the one last question for you. I just seen this now, sorry. With respect to reason for shift in the projected peak of case incident, isn't it appropriate to mention delays in obtaining results as a factor? Receiving results in 3 to 8 days will surely impact the decision to isolate and hence reduce spread. That's a very good question. Greg, you take that.
Okay, sir.
All right. So.
Okay, thank you so much, CMD. And thank you for everyone for throwing in your questions. As regards death of healthcare workers in Edo State, none has been recorded graciously and happily because there is serious machinery to follow up healthcare workers and ensure that in the first place there is even no nosocomial infection, much more deaths. Secondly, with respect to asymptomatics, what the evidence have shown is that they can transmit, and this transmission is most intense 2 days before they present with symptoms and up to 5 days after they actually have symptoms. So that is like the infectiousness period, which is actually different from the incubation period. But within the incubation period, before they present with symptoms, they can transmit, and it's most intense 2 days before. Then with respect to the shift in the peak of case incidents, surely the testing will affect because you need a confirmatory test to be able to know that this person should be isolated, and therefore that will impact on reducing transmission. However, we must say that confirmed cases alone are not the defined case. We have probable cases and we have suspected cases. So if we are able to improve our isolation with respect to suspected and probable case and keep them away from other people, especially those who are vulnerable, like the elderly and the immunocompromised, then that will also help to have control the peak. So yes, this could have contributed to the shift in the peak. And also, I was asked to elaborate on the symptoms as related to the classifications of the severity. The clinical pillar will stress more on that when they make their presentation. But in terms of classification of severity, if there is a respiratory disease involvement like pneumonia or any other end organ damage, I think that throws it into a severe case. But there are other criteria for determining severity other than that. Also, I think I was asked to also explain the mortality rate in UBTH is very high. Indeed, yes, we are having a very, of the 40 deaths in Edo State, 36 or so is from UBTH. Yes, we are having that, but this is it. UBTH is is actually arguably the most patronized referral center in South Nigeria. That's one. Two, also UBTH, the cases we've had, more than 80% die within 24 hours of presentation. So which means that according to the epidemiology and statistical computation, those cases are severe cases, and those cases does not reflect the UBTH in terms of our services. It reflects the severity of the cases. So if we exclude the deaths that occur within 24 hours and we compute a metric referred to as the net mortality rate, you will just realize suddenly that the mortality rate in UBTH indeed has dropped. And lastly, to add to that layer of explanation is the fact that the most cases we had in UBTH are very severe cases with comorbidity that are almost always end stage. So UBTH is actually performing in terms of providing care. It's just that we are receiving the most severe of the cases. I think this actually should be the questions that, yes, somebody also asked something about the senatorial districts in Edo. Confirmed cases are concentrated in Edo South. Do we have enough testing centers in other senatorial zones? The answer is yes. We have a testing center in the Edo Central, which is ISTH, which is actually one of the foremost infectious disease center in the country. We also have facilities in Edo North for testing. And just to let you know, within a period of about 2.5 months, the state government embarked on a statewide screening, and the screening
we can still take 5 minutes of questions, sir.
Also, no, Greg. Hello.
Sir.
Yes, what we'll do, just take time to write out some of the questions. Let's not take it off the cuff.
Thank you.
While I share at this juncture, I share the results of the poll that was conducted. Let me see whether we have it here. Yes. So Greg, you look at the questions and write out 2 or 3 more when I shared it. Thank you. We did a poll before we started the presentation, and the result is out. The first question was, what do you think about COVID-19? A, it is a horse, as fake. Nobody said so. Nobody agreed. It is real, 100%. Everybody said it's real. This is very gratifying to know. Question number 2, do you think healthcare workers are properly remunerated in the fight against COVID-19? 40% said yes, 75% said no, and 12% are not sure. Number 3, healthcare workers are disproportionately affected by COVID-19 virus. 62% said yes, 20% said no, 90% are not sure. And question number 4, do you think the government has adequately equipped the public hospital in the fight against COVID-19? 86%, whopping 86% said no, while only 4% said yes. So these are very revealing, and we will use it to for our intervention and cascading to relevant authority. Thank you. So Greg, you can select 2 more questions and take while we wait for move on to the CMAC after yours.
Okay, sir. Should I go on, sir?
Yes, please go on.
Thank you, sir. Okay, I would like to pick the question on herbal remedies. Yes, there are so many claims of herbal remedies across Africa, but what I just want to say here is science has methodology, and from what it is now, there is no herbal remedy that has gone through the scientific rigor to warrant use in a hospital setting for the care of our patients. I want to say that we need to upgrade our thought process with respect to the validity of treatment options. The world has moved on. Just someone who has public following claiming a herbal remedy for COVID-19 or even any other disease is not enough for us to confer validity on that particular treatment option. That is laid down scientific process that should be followed, and that is what we actually clamor for, and that's what we listen to. Evidence based on rigorous scientific research. And as at today, no herbal remedy has passed through that fire to show that it can be used. And the other questions the other question I would like to pick is that there is a question that is, will the virus come to an end, or should we learn how to live with it? That question is a two-edged sword. Yes, the way it's going from our models, our epidemiological model, this virus may not come to an end within the nearest time. In fact, why not trying to scare anybody? We are expecting a second wave of the virus spreading again. Some countries in Europe are already having the second wave. For Nigeria specifically, from what the model is telling us now, even with some level of uncertainty, is that there may be a second wave close to the end of this year. So we may just learn to live with the virus. And living with the virus simply means individual and community social distancing has to be titrated against our socioeconomic realities, so that we don't so much lock everybody up and for the sake of COVID-19, while we are also breeding hunger, which can lead to other cascade of medical and public health problems. So that we need a balance, and that is actually at the foot of our governors, our leaders at the national level, to see how we can titrate the social distancing issues as well as socioeconomic realities of our people. So we just have to learn to live with it. We have been shouting on this over time. It's not just for COVID-19, even for other conditions. We have to learn how to live with this. Then the last one I would take is, do we say Nigeria is doing better than South Africa? Isn't the graphical presentation dependent on the number of testing done? Well, on one hand, I would say in terms of testing per 100 million population, South Africa is doing better. They are testing more of their people compared to Nigeria. But on the other hand, cases of COVID-19, especially the severe cases, is not dependent on testing. If somebody is sick with COVID-19 or of COVID-19, the person will present to a health facility and the person will be tested there and then. In such instances, we cannot say it is testing that brought the person. It is this ill health. And from what we are seeing right now, testing does not determine who really present with the severe cases. Severe cases are independent of testing. So it's not as a result of testing, which is being pushed by a very popular world leader in the Americas, but that's not true. Cases are cases, and they will come to the hospital and they will know this person has from our own testing at the hospital, irrespective of screening or testing in the community. So at this point, I would like to say thank you. I may take other questions as we go along, and thank you, CMD.
All right. Thank you, everybody. Before we move on, I just have a change of program a little. The Director General of Nigeria Center for Disease Control is on the call. That's Dr. Chikwe Ekwazu, but it's being represented by Dr. Tochi Okwo, who is the head of the Antimicrobial Resistance and Infection Prevention and Control Unit of NCDC, Nigeria. So, Madam, we are very happy to have you, but I don't think that you are allowed to say anything just yet for sake of time. So, because of you, I want to reorder the other presentation. Let our Infection Prevention and Control Committee wing take the next presentation before the case management pillar. So we'll call on Dr. Esoe Bodo to take the next presentation.
Good morning, sir. Good morning, all. And welcome to this webinar session. Permit me to share my screen, sir.
Yes, please go on.
So we'll be talking about the infection prevention and control and surveillance activities in the University of Benin Teaching Hospital during the COVID-19 pandemic. And I will be using this outline. So I just want to give a brief introduction about infection prevention and control and surveillance. Infection prevention and control is a scientific approach and a practical solution designed to prevent and control the spread of infection in healthcare facilities and in the community. It occupies a unique position in the field of patient safety, and it is well grounded in infectious diseases, epidemiology, social sciences, and health system strengthening. Looking at the chain of infection, looking at the epidemiology of any diseases, there are 6 places or 6 points where we can break the chain of the infection at the level of the microorganism, the reservoir, the portal of exit, the mode of transmission, the portal of entry, and the susceptible host. And at this point in time, if it is at the microorganism level, prompt diagnosis and treatment can help to break this chain. Disinfection and sterilization at the level of the reservoir. At the portal of entry, we can use hand hygiene, control of aerosols and PPEs. And also, when we are looking at the mode of transmission, we can also use hand hygiene, PPEs, cough etiquette, and social distancing, all the way to susceptible hosts where health education, immunization, and treatment of underlying diseases will help to break the chain of infection. Surveillance, on the other hand, is the ongoing systematic collection, analysis, and interpretation of health data that is essential to the planning, implementation, and evaluation of public health practice. Surveillance activities help us to enables us to detect and respond to epidemics, and through surveillance, organizations and other facilities gather data regarding infection patterns at their facility, and they regularly assess, and this can help them to regularly assess the current infection prevention and control protocols. So both infection prevention and control and surveillance are public health strategies that are focused on preventing the spread of diseases. And prevention strategies and intervention from both fields are aimed at medical care practices, human behavior, and the environment. This slide helps us to understand the rapid response team composition and where the infection prevention and control lies. Here, we are closely linked with the case management team, and we also act as the epidemiologists because we conduct contact tracing. Also, the social mobilization specialist, the risk communication specialist, and the laboratory specialist, in conjunction with the case management, of course, and the IPC, form the rapid response team. So naturally, when the COVID-19 response team was formed, we immediately got members from our infection prevention and control committee, some members into the COVID-19 response team. And apologies to our members whose pictures is not shown here, but this was a very chance picture, and we love to use this picture because our CMD, our amiable CMD, is right in the middle of this picture, and he's where we are solidly behind him because he's the one in front. So going to our activities, let's look at our infection prevention and control activities. For hand hygiene, we have ensured the provision of water, liquid soap, and hand sanitizers in all areas of the hospital, the wards, the clinics, the admin areas. The CMD, showed some pictures of what the management had to do to ensure that these hand hygiene facilities, are readily available. We know that hands play a crucial role in the transmission of COVID-19, and COVID-19 is spread primarily through droplet and contact infection. When Dr. Greg was speaking, he took us through the mode of transmission of the disease. Concerning personal protective equipment, we liaise with the clinical services, for local production of our coveralls, aprons, and cloth face masks. And we also work with the logistic and supply chain for the distribution and the effective distribution of these personal protective equipment. As regards waste disposal, we ensure the incineration of all waste from isolation ward, and we also ensure the proper disposal of our used face masks in the hospitals, in all areas in the hospital. As regards respiratory hygiene and cough etiquette, we made the recommendation to management to enforce the no face mask, no entry policy. With linen services, we had to update the standard operating procedure for disinfection of linen in line with best practices to ensure that our linen were appropriately disinfected and before reuse. And as concerns the environmental cleaning, we ensure regular disinfection of all surfaces in the wards, clinic, and other areas with hypochlorite solution. We are also members of the research team in the pillar, and amongst other research that we are carrying out in the COVID-19 response is the knowledge and compliance to IPC measures during the COVID-19 pandemic. This work, it has reached almost completion, near completion level, and we will be publishing very soon. As far as collaboration is, we liaise with the state IPC pillar to ensure that infection control, prevention and control practices in the isolation wards, and indeed in all other areas of the hospital, are adhered to. For health education, we support staff were educated on proper disinfection of surfaces, proper disposal of used face masks, and we always ensure spot checks on the compliance with IPC measures among healthcare workers by the pillar members, and we also give on-site education as is necessary. Environmental health, the environmental health unit has been very active in this fight against the COVID-19, and we perform twice daily disinfection of our isolation wards. We also perform terminal disinfection of wards and clinic following exposures, and we have done a general hospital-wide disinfection. And we also had to go to the house officers' residence to disinfect their residence to mitigate an outbreak of COVID-19 among us house officers, because later in the presentation, we'll notice that they are a high-risk group in terms of our healthcare workers. Surveillance activities, we have performed contact tracing, and we also perform risk assessment of healthcare workers within the hospital that are exposed to confirmed cases. An appropriate recommendation following this risk assessment is made. The risk assessment tool that we use was adopted from the WHO tool called the Risk Assessment and Management of Exposure to Healthcare Workers in the context of COVID-19 interim guidance. And this risk assessment tool helps us to determine the risk of COVID-19 virus infection of all healthcare workers who have been exposed to COVID-19 patients, and also provides recommendation on appropriate management of these healthcare workers according to risk. And so this is what we do, and we place our healthcare workers either as high risk or as low risk following exposure to COVID-19 cases. Also, we also, members of staff who become symptomatic, whether within the hospital or not, members of staff who become symptomatic are encouraged to communicate with IPC, and in turn, IPC liaises with the rapid response team for testing. And this has also helped us in, because of the no blame policy of the hospital, this has also helped us to get a lot of our healthcare workers who have symptoms of the disease to open up and come out for testing. This figure actually shows the contact tracing statistics for COVID-19 from 3rd of April to July 1st, 2020. Our first major exposure was on the 3rd of April, where we had a whooping 80 members of staff that were exposed to our index patient. And so far since then, we have contact traced 943 persons. Of course, we sometimes have to contact trace one person more than once or twice, depending on the exposure or the patient that the healthcare worker was exposed to. Of all these, high-risk contacts are about we have had about 311, we have had 311 high-risk contacts, representing 33% of this number of persons contact traced. And we were initially quarantining our high-risk contacts for 14 days, but management decided to take a more aggressive tone and decided to start immediately testing our high-risk contacts. And so far, we have tested 224 persons, of which 20 representing 8.9% of the high-risk contacts, or representing 8.9% of the persons tested have come out positive. On the right-hand side, it speaks to the occupational groups of the persons that we contact traced, and the persons that fall into high risk, and the persons that have turned out positive. And in all the bars, doctors have come out on top, and we have more doctors positive now than any other health worker. This figure is a fallout of the figure 1, which just shows the sex distribution of the people contact traced, the people who formed the high risk contacts, and the number of persons who were positive. So whereas in terms of management and severity of the disease, we find out that we have more males than females. Here, we are finding out that we have about equal number of our healthcare workers that are positive as a result of our contact tracing. We know that there are 43 healthcare workers that are positive, but through contact tracing and through our surveillance activities, we have 20 of those 43 we are getting from contact tracing. So if 20 of the 43 were gotten from contact tracing, other healthcare workers came into the facility, came to us to say, I'm not feeling well, even though I have not been exposed to a patient in the hospital, or I'm not aware of any exposure within the hospital, but I am not feeling well. And they came in and they tested. Now this, in an indirect way, shows the level of community transmission that we are seeing now in the state. Statistics from Edo State shows now that about 73% or over 73% of the COVID-19 positive results are through community transmission. And we as healthcare workers who also live within the community are not immune rather from community transmission. And we are beginning to notice that we are more sensitive within the health facility and a bit less sensitive when we come out of the health facility as regards our infection prevention and control measures. And this is one angle that we need to tackle. So let's look at our progress and challenges. How have we done so far? Our progress steps. We have noticed an improved uptake on the use of personal protective equipment all around the hospital. This is highly commendable, but we can do more. In terms of hand hygiene compliance to hand hygiene has greatly improved from 48.2% in a study that was conducted in 2013 to 84.9% in our unpublished manuscript, our unpublished research that we are performing now. This lays credence to the fact that the management has ensured that hand washing facilities are readily available, and hand sanitizers are also readily available. So this is kudos to the management of the hospital. Also, for waste disposal, we ensure waste segregation and disposal, and these have improved. We have bought dino bins, we have color-coded bins and color-coded bin liners, and we try to ensure that the logistics and supply of these bins and these bin liners are effective. Also, used face masks are now properly being disposed of. When the whole world was faced with the challenge of wearing face masks, we noticed that face masks were beginning to litter the facility, but with improved health education, especially of our support staff, this has greatly improved. We also are very happy with the level of collaboration that staff are having with the infection prevention and control community. And I also want to pin this on the no-blame policy that the management has adopted, where we don't even sanction anybody if you were exposed in spite of the fact that if you were exposed in spite of the fact that PPEs were made available, we still take you, test you, and accord you the same service that would have accorded any other person. Also, escalation of suspects by members of staff. We are seeing a huge culture of see something, say something within the hospital. And so escalation is not reporting. And we are noticing that a lot of people are, telling us, giving us insights in their departments, in places around the hospital. And so we are very happy about this, and we are using this to our benefit. Of course, we have challenges. We are still in some foci of areas. We are still seeing complacency on the use of face masks and other PPEs. There is this huge challenge of non-adherence to the one visitor, one patient policy. We are not police officers, but we try our best to speak with patient relatives and ensure that they wear their face masks. And say at a time, we just need only one visitor per patient. This is difficult, but we are still trying our best. The non-use of appropriate PPEs by healthcare workers, despite its availability, is another challenge. And then the poor implementation of clinical management protocol on flagging suspected cases. Once or twice, we see this within the facility, and then we see that a suspected or a flagged case has sieved into our ward or our facility. Also, we are seeing an increased vulnerability of our healthcare workers outside the facility. And a good example for this is a lot of our house officers are coming down with the disease. They form the highest proportion of healthcare workers who have come down with the disease. And this necessitated us going to do terminal disinfection in their halls of residence. We have noticed that when they gather, because they are in communal settings, they gather, they watch TV, they play without ensuring infection prevention and control measures. When one is sick, goes to the other person's room, and that person tries to tend to them. And so this is a huge challenge that we are facing within the hospital premises right now. In conclusion, I want to say that the infection prevention and control surveillance pillar is at the forefront of combating the spread of COVID-19 in UBTH. Also, guidelines and policies aimed at improving infection prevention and control measures in the hospital have been made and circulated, and strict adherence to these policies and guidelines are key in mitigating the spread of this disease. Our take-home message: appropriate use of PPEs should be encouraged. Strict adherence to the implementation of the clinical management protocol on flagging suspected cases should be maintained. And also, we should maintain strict adherence to one visitor, one patient policy in the wards. We must be advocates of standard precaution. And Infection Prevention and Control Committee is committed to partnering with all of us as change agents. Of course, we can't, as infection prevention and control specialists, we cannot go without leaving this message. Always clean your hands, always wash your hands, either using soap and water and alcohol-based hand rub. Clean and disinfect all frequently touched surfaces with disinfectants. Seek medical care promptly if you are sick, and avoid close contacts with others. Use your face mask when in public places and at all times. And then we have to practice social distancing by maintaining at least 1 meter distance between yourself and the other person. This quote I first heard from the CMD. He said, "Never let a good crisis go to waste." And when I pondered on it and Googled it, I found out that he was actually quoting Winston Churchill. And I think that this quote is very important, even as in Winston Churchill's time, as it is in our time. And so whatever we are doing during this pandemic, we should not let this time go to waste. This is a time for us to improve ourselves individually and collectively. That book you want to read, that research you want to write, let us spend our time wisely in doing whatever we need to do to improve ourselves, especially during this pandemic. I want to leave this slide while I make my acknowledgements. I really want to acknowledge the dynamic management of the University of Benin Teaching Hospital, led by our very agile CMD, Professor Darlington Obaseki. This is the best time to work with management, I can tell you from experience. I also want to thank the Department of Community Health, where public health leaders are trained and are nurtured. I want to thank the Infection Prevention and Control Committee, who are made of dedicated staff. And lastly, I want to say thank you to the rapid response team that are made up of doctors, nurses, pharmacists, paramedics, environmental health officers, cleaners, porters, who have gone above and beyond their call of service. Your names are written in gold. Thank you for being a very wonderful audience, and thank you for the opportunity to serve. These are my references.
All right, thank you, Dr. Isaiah Bodo, our brand new head of Department of Community Medicine, University of Benin Teaching Hospital, and chairman of the Infection Prevention and Control Committee, UBTH. We are blessed in this hospital with such high-level resource persons. Thank you so much. I said earlier that Dr. Tochi Okwo is on the call. We have added that to the list of panelists. Dr. Tochi, I'm sure you will wait a few more minutes before you speak. Let Dr. Professor Kasmo take his presentation. I hope you don't mind, please. Tochi, yeah?
I'm super excited. What I've heard is just so exciting. I am here all the way.
God bless you. NCDC is doing a fantastic job for the country, and we in UBTH we are very much appreciative on behalf of the community of UBTH. Edo State, say thank you to NCDC and your DG bringing you here. We are very much appreciative. Professor Kasman will talk to us on the case management thus far.
Thank you, CMD. Thanks, CMD. Good afternoon, the Chief Medical Director and all distinguished persons here. I'm here with Dr. Benson Okwara, who is the team leader for the Rapid Response Team. I'm sharing my screen now. So, we're going to discuss about the profile of COVID-19 patient management in UBTH. This presentation is tailored because we have a mixed audience. So you please bear with me for making the adjustments that are necessary. I'm going to discuss this with the following outline: the historical milestones, patient care case summary, mortality in COVID, and COVID infection in staff, the challenges and our new frontiers. We'll conclude with that. But I'd like to start off first with how we began this whole process. I bring here a message of hope because in the face of this COVID-19 pandemic, the hospital is actually the last frontier. We're not the first frontier, we're the last frontier. And when all infection prevention and control measures, other things have failed, and the patients come down with it, we are the ones who manage to handle the patients. It's with this sense of humility that we realize that we have a major task at hand. In the beginning, when the pandemic first started, we were afraid that the way things were, we were going to be in a very, very bad state. Like you can see, this person was trying to make a journey and had to use extreme measures to try to get to where he's going. This is a picture taken from the Vanguard. I believed at first that we were going to face a situation like this. I'm very glad that the picture is very, very different and there is hope. We've all gone through these historical milestones before. We realized that the first case in UBTH was on the 4th of March, the first suspected case. And then we now had our first confirmed diagnosis on the 31st of March. Since then, we have a total of 163 confirmed cases, 104 males, 59 females. Unfortunately, males have been very, very unfairly treated. Now, we have a rapid response team. It's a robust multidisciplinary team of dedicated staff that handle testing and treatment of all suspected and confirmed cases of COVID-19. As the Chief Medical Director has already pointed out, we have a 24-bed isolation ward and the other areas we take care of our patients, including a 2-bed ICU. This picture just shows a few of the areas. The pictures above show the outside of the isolation center, and the pictures below show the interior of it, with Dr. Kwara attending to a patient right there. Now, our patient care, I'll hand over the presentation now to Dr. Benson Okwara, who will handle patient care.
Good day all, thank you for having me here. I basically will start by saying that hospitals are built not because we want people to fall ill. Hospitals are built not because we cannot prevent people from falling ill, but we know that people will still fall ill. And definitely when they fall ill, they have to get somewhere where they can receive care. As has been presented much earlier, we've had cases in UBTH, right from the first confirmed case on the 31st of March. As of 30th of March, 163 confirmed cases. And patients generally receive supportive care and definitive treatment for their comorbidities. As you can see on the slide, there are some drugs that have been used for trials in some other countries. Back and forth on the use of hydroxychloroquine, lopinavir, ritonavir, dexamethasone recently, and now we also know about remdesivir and other medications. Presently, we don't have any prophylactic treatment, no post-exposure prophylactic treatment. All patients and interested staff have psychosocial evaluation done directly or via electronic channels, because people come to the isolation ward. For those who can receive call, they give them call. For those we can talk to directly, we go to them and talk to them. We have ICU care that is available, but not yet utilized. I can say with confidence that the level of care we provide for our patients who get into the isolation ward, of course, without the use of ventilators, approaches that of ICU care. We give them due care. We follow up their cases as much as we can. And other disciplines are actually invited also to help to provide care for these patients. Now, let me go to this case summary. Since we first started, 163 confirmed cases. Presently, we have those that are active, 50. And I could just break it down. We are having a lot of patients who have very mild symptoms, particularly those who are contact traced. Those ones we cannot get into our facilities because of limited space, but we monitor them. And as has rightly been spoken to earlier, we've had no mortality from any of our patients who are in home management. So we have 50 active cases presently, 35 males, 15 females. We've discharged a total of 77, and I could just break it down further. Of these 77, unfortunately, 6 of these patients actually decided to discharge against medical advice. 4 of them, before their results were made available, then 2 who had their results made known to them, but they still insisted that they don't believe in COVID and had to take their wards home. Then we had to transfer 1 patient to a sister institution because we didn't have space at that time. And I can reliably inform you that the patient has been discharged from care. But in spite of all of this, unfortunately, we've had mortalities. As of 30th of June, 36 mortalities. And because of the trend that is happening right now, the mortalities are more in the elderly group, those more than 60 years of age. In fact, of the 36, we've had 21 who have died, which represents about 58%. So we are seeing more of our elderly patients, those who are vulnerable, who have comorbidities, coming down with the illness and dying. So that means we need to do much more for this vulnerable group. And this is the breakdown for the mortalities. 21 to 40 years, 5, all males. 41 to 68 for males, 2 for females. More than 60 years, total of 21, 15 males, 6 females. Now, one could just ask the question, why are people who are less than 40 dying? And we have to aggregate this number together. 4 of these persons had trauma-related incidents. 2 road traffic accidents. 1 was assaulted by unknown persons. The other one was actually a traumatic brain injury who had been in the ward for more than 4 months, for more than 3 months before he was diagnosed as having COVID. The only one that is less than 40 that we could say probably may be a COVID death. But of course, without autopsy, we may not yet prove that was a 26-year-old male who came in very ill, was diagnosed as diabetic, and had acute kidney injury. In fact, would have needed dialysis, but of course, he even died before the results were made available. So that explains why you can see 21 to 40. Other than that, we wouldn't have had mortality in this age group. The 21, as I talked about earlier, that are the ones that are more vulnerable, more than 60 years of age, over 58% of them have died. Then we're going to go into the breakdown of the duration of survival after diagnosis. Most of the deaths to what during this period were made available. Then, of course, more than 24 hours, we have 5, 2 days, 5, 3 days, 3, 4 days, none, and more than 5 days, which included the man that was in hospital admission for more than 3 months. We have 4. And we had patients, most of the patients who are dying had significant comorbidities. Hypertension, hypertensive heart disease, congestive cardiac failure, and diabetes mellitus grouped together represents the largest number. 20 of these patients who died had these conditions. We've had 2 patients who had history of diagnosis of CA prostate. Then chronic kidney disease, 2 persons. We had a patient who had post-renal transplant. We actually didn't want to admit him into the isolation ward initially because he was on immunosuppressants. And we were careful that he may just not go so that he doesn't pick up any other infection. But when we noticed that he wasn't doing well, he was asked to come in. And we did a renal function test and we found that his renal function was really bad and again may have needed dialysis, but he succumbed to his illness. The other comorbidities include COE, a patient with severe post-stroke seizures, then other events that I talked about earlier, road traffic accident, trauma-related, assault, and all of that. I will invite the CMAC to talk more on this number of the staff infection in the hospital. Thank you very much.
Thank you, Dr. Okwara. So regarding our staff in UBTH, the COVID infection in our staff, a lot has already been said about it, and we are very grateful that no deaths have been found. This figure of 43 represents healthcare workers purely. We do not have any non-healthcare worker that has been diagnosed in UBTH and been on management. We do have a few healthcare workers from other institutions, but they do not form a part of this figure that is listed above. Now, taking a spread of the location where these staff were, it has already been pointed out that the doctors form the largest group, and find that the departments from which where they are domiciled is widespread, from pediatrics to dentistry, neurosurgery, family medicine, anesthesiology, OBGYN, internal medicine, pathology. So no area is really safe. Same thing, find that the spread for all the other professionals is the same. They're all over the hospital. However, I want to point out one simple fact that was mentioned earlier by the Infection and Prevention Control, which was that the source of infection in these cases cannot necessarily be traced directly to the hospital in all cases. We have a few challenges regarding the care of our patients. Accommodation challenges. The holding ward is overwhelmed with cases who are being tested or awaiting their results, and this is currently being restructured. Staff shortages and delays in testing and limited testing capacity have already been mentioned previously. We also have severe logistic problems with radiologic investigations, dialysis, surgeries, and other interventions because of the need to have these patients tested and in the care in preventing transmission of this COVID to our staff. I would like to close this presentation with mentioning a few new frontiers we are having. Things like splitting the case management pillar into separate functional units so that each unit can function more efficiently. We're also handling staff tracking and testing separately from the other patients. We're restructuring the holding area and the patient flow processes to accommodate this rising number of patients that we've mentioned before. We also are considering domiciling investigative and other clinical interventions within the isolation ward. For instance, the placement of a mobile X-ray unit within the isolation ward and the attendant equipment required to make it functional. At this point, we also have to realize that COVID is going to be with us for a long time. So the rapid response team alone cannot manage this. We're therefore working on capacity building such that all clinical staff will be able to handle care of COVID-19 patients. And this will involve a lot of work from everybody. We are already very grateful for the efforts that so many people have put in already. We're also looking at some other avenues of taking care of our patients, things like COVID clinics, virtual clinics, hotlines, and co. And they are being activated as we speak. I want to close with this last quote. That this presentation is dedicated to all the courageous men and women who are toiling tirelessly to keep COVID-19 at bay in the background. When this thing started, there was a lot of fear and misunderstanding, and these people came out and volunteered to handle the unknown. Nelson Mandela says that the brave man is not he who does not feel afraid, but he who conquers that fear. And these men and women conquered that fear. I salute all of you. Thank you for listening.
Well done, Simak. Well done. Dr. Benson Okwara, nice job. Very, very well presented. We have just one last presentation by Dr. Stanley Okugbo. But before we take his presentation, ICT, I don't know whether you're ready to share the results of the second poll. Yes, please, thank you. I hope you all can see it. The second poll that we did, how soon do you think COVID-19 pandemic will end? 32%, very optimistic people. I wish I was in this category. Say very soon. So almost 70% say it has come to stay with us. Very good. And 1%, 2 persons think it's, so it's even if we are through with it. Very interesting. Second question, the no face mask, no entry policy within the hospital, is it necessary? 94%, this is gratifying. Says very necessary. 7%, somewhat necessary, only 1% not necessary. How best can we tackle the spread of COVID-19? 19% say comply with social distancing laws. 0%, interesting, said did not agree that we should institute lockdown. Very interesting. Compulsory use of face mask, 18%, while 62% said all of the above. These are very interesting data that we will share, that we will use for our intervention statewide, not just for UBTH. Thank you so much. So we will now call on Dr. Stanley Okugbo, the Deputy Chairman, Medical Advisory Committee of Monitoring and Training, to take the last presentation, which is on how we have managed to keep the hospital running, logistics and supply chain. Stanley.
Good afternoon, Mr. CMD, sir. Good afternoon, ladies and gentlemen. It's my privilege this afternoon to present how we have been keeping the hospital running from the aspect of the logistics and supply chain management. I'm going to be using this outline for this purpose this afternoon. What is logistics and supply? It's all about ensuring processes are in place so that the end user can actually receive the product that they came for. In this case, healthcare services, what we are delivering in UBTH. Due to the identified threat from coronavirus patients, whether they are symptomatic or asymptomatic, there was need, or there is need, for workspace rearrangements, deployment of, and change in the way we deploy services. There was a need for a complete overhaul. And there was a lot of widespread concern about patient to patient, patient to caregiver, relatives and accompanying persons of patient to patient and to caregivers, transmission and vice versa within the hospital space. Now, for supply chains disruptions, this is something that all of us are aware about. The main capitals of manufacture in the world, China and India, could not even meet up the demands that accrued because of the stress that came on the healthcare systems worldwide. And that's a quote by the Director General of the World Health Organization, who was talking about how we must secure supply chains. Otherwise, we risk having problems with healthcare workers around the globe. We also must remember that as a nation, we also have poor national strategic storage, if at all we do have. So the pandemic itself has come at a time globally we were not ready for. Now, our pillar had these terms of references. One, which is first to identify the needs of management of COVID-19 patients in UBTH. And the second was to ensure that we have adequate supply of all materials in all the areas involved in the management of COVID-19. And I will see later that this practically covers all the hospital. Ours was also to liaise with the external bodies towards ensuring adequacy of materials through donors, donor agencies, NGOs, and governmental agencies, and to coordinate the supply and provision of materials required to ensure continuous healthcare delivery. The members of my team are stated in this slide, from the head of procurement, Mr. John Gujak, to head of stores, Mr. Akpan, Mr. Victor Ojigo, head of protocol, Hajia Mohammed in audit, and the indefatigable head of pharmacy, Mrs. Olumese, and the engineer in charge of the A&E, Sonny Wasa, and Mr. Amos, the transport officer. As a background to this presentation, we must remember that UBTH was in the middle of the Lassa fever epidemic in Nigeria when we had our first case of SARS-CoV-2 in March 2020. The hospital was consolidating on the gains of improved services, high patient load, and bed occupancy rate, motivated workforce when we were blindsided by this pandemic. But a lot of things stood us in good stead, which were our strong points. One was our universal availability of soap and water, running water all over the hospital, good hand washing culture uptake, which the hospital had gained, freely available consumables all over the hospital space. We also had a very robust engineering department, pharmacy, linen services, as well as other support services, including infection control units. And then we had liquid soap dispensers, hand dryers, and sanitizers already available within the hospital space before the advent. Immediate need assessment by the hospital, thank God for the able leadership of the CMD, we realized quickly we needed some infrastructural, there were some infrastructural needs, some of which have been highlighted earlier. And some of that was need for triage points, because we have to change the way we do business in healthcare. There was also need for holding areas for suspected cases. There was need for isolation ward. There was a need for a new medical emergency room. I'll talk about that a bit later. And then there was a need for us to start testing patients in UBTH by way of a PCR lab. We also needed to have workflow dynamic changes, and then we also need to ramp up procurement and we got on with it with the aid of our engineering department. We made canopies, which we deployed in the general practice clinic, the consultant outpatient department, ophthalmology, and medical A&E. Until today, those canopies are in place where they help to reduce overcrowding in those areas, and we can ensure social distancing measures for patients ready to receive services. We also produce drums for hand washing, and they are all deployed at the entry and exit points of the hospital and as well as major clinical areas. We increased the production of sanitizers in our pharmacy lab where they were already being produced before now, and made them available freely in all the clinics, in the wards, and in fact in all the clinical areas, and were even supplied free of charge to staff for personal use. We procured infrared thermometers and pulse oximeters for use at those triage points, and we employed 33 paramedics to man them. This is a outlay of the reusable gowns, aprons, and fabric face masks, which the hospital ramped up production from the linen services. And these are all the distribution points all over the hospital. As of today, we have distributed well over, and we have made and distributed well over 1,521 protective gowns and over 600 aprons, impervious aprons. We also realized that we also needed another layer of protection by way of face shields, and because of cost of procurement, lockdown measures all over the world, we needed to have local production. And the engineering people were, engineering department was involved in that regard, and we have, you can see the outlay of distribution all over the hospital. As at present, we have distributed well over 700 cases and shields, and more are still being produced as because we have not been able to meet up all the needs in the clinical areas. We also procured goggles and N95 face masks, and we distributed them widely all over the hospital. And you can see the outlay there. As for infrastructural changes, we had a small outsourced lab within the accident and emergency complex, which was being used for holding area for Lassa fever patients and monkeypox patients before now. So we needed to really create a proper isolation center, and that immediately we went about doing. In fact, during the process, we had to do a lot of floor design and oxygen piping, donning and doffing areas, and air conditioning units were procured. We also had multi-patient parameters and beds, suction machines, and even had a new mobile X-ray machine board for use in that isolation center. However, this isolation center quickly became too small for the number of cases that we were seeing, being just an 8-bedded unit. And together with the help of the Edo State government, we quickly repurposed our emergency room into a 24-bed isolation ward. And there's a complete revamping of the whole emergency area towards clean and dirty areas and patient areas. And we had oxygen piping, air conditioning, and so many other services produced, including furnishing. And right now that facility again is already full. With the use of the emergency room as an isolation center, we needed to create a new emergency room. And the area in front of the accident and emergency lab was quickly repurposed into a triage area. And then the old children emergency room was repurposed to house the new emergency room. The old plastic ward was refurbished and repurposed into an holding bay. And presently, right now, we are using the accident and emergency ward as a holding area because of a lot of cases that are being flagged, suspected cases that are arriving in the hospital. With all the production of the reusable scrubs and all that materials that we are reusing, we realized that quickly that we needed to revamp our laundry services. And so we immediately went about to build a new fully functional laundry situated in the accident and emergency complex. It is equipped with 2 industrial-sized washing machines and an industrial-sized dryer. It serves the purpose of cleaning for the whole emergency complex. And we also revamped the old Vamed hostel, which has been turned into a transit ward. and it's a step downward for patients who are recovering from COVID. We, as part of diagnostic, improving our diagnostics for ensuring proper treatment of our patients, we went into an MOU with the Center for Reproductive Health Initiative led by Professor Friday Okonofor to lease their PCRO machine. And we also had to do a lot of expansion work and redesign of the floor plans and upgrading of offices within the area of our molecular virology lab, creating donning and doffing areas, reception and other areas. It was the whole effort has produced a world-class lab that has been certified by the NCDC in Nigeria. And together with the Edo State government, with their tremendous support, we are presently able to test patients in UBTH. We also quickly realized that we could not continue with many of these consumables without trying to reuse some of them. And since we know that best practices, there are opportunities for reuse of some materials so long as you have adequate re-sterilization and cleaning. So together with the engineering department, we created two chambers, two ultraviolet light chambers. We'll show you some of the pictures at the end of the presentation, where they are already being deployed. One is in the accident and emergency trauma unit where it's being used presently, and the other is in the intensive care unit. We also realized that with increasing cases of COVID patients presenting in the wards becoming flagged, we needed to have workspace disinfection and cleaning. And we have provided two mobile units which can be used to clean up areas like areas in the dentistry, ENT areas where there are concerns about aerosol generation during normal work procedures. Also, we quickly realized that there was a lot of concern and fear among patients about coming to access care in UBTH. And there was we realized that many patients wanted a situation where they could still get their care with their doctors without being physically present in UBTH. We had a partnership with the Outpost Health virtual clinic, which commenced within the first week of April in 2020. And presently that is running. We piloted it first in the general practice clinic, and we are rolling the services all over the hospitals and getting some HMOs on board already. Presently, we are about onboarding payments on the platform. We have had challenges, tremendous challenges, in fact, because these are new terrain for us to travel. One of the first important challenges has been the astronomical increase and demand for consumables across the hospital. Consumables that usually would not be used are now being used, whether it was surgical face masks, whether it's disinfectants, whether bleach sheets, latex gloves. We have also had overconsumption of hospital supplies, sometimes nearly waste when you look at it, because of the increasing concern about how to protect yourself against contracting the virus. We have also noticed that many of these consumables are not captured in our payment schedules. So essentially, these consumables are being expended without being paid for. We also noticed that there was also a lot of theft, both for our surgical face masks and even other equipment within the hospital. And this has been a big challenge in helping us in continuing services in many of these clinical areas. Of course, with all of this, there's a depletion of our revolving funds, and you know that the hospital runs on IGRO, internal generated revenue. So this has become an increasing concern because we are going through some kind of debts with many of our contractors and providers. There's also increased anxiety among caregivers across the hospital, and that increasing anxiety has worsened the care that some patients would ordinarily have gotten. And there's also increasing cases of COVID-19 presenting in our emergency, which is all fueling some of the anxiety and some of the behaviors that we have noticed. It's all not doom and gloom, actually. there's a lot we can do. And in trying to conclude this presentation, moving forward, we will require departments to develop standards about how to continue to render services in the face of this pandemic. All hands must be on deck, because like many people are saying, and the Director General of the NCDC has said, it will seem that COVID is here to stay with us. We have to learn to live with it. So where possible, reusable materials should be used as they present a sustainable model, because Nigeria is not a manufacturing country and the resources are lean for us right now. Items that can be sterilized or disinfected should be sterilized and disinfected, whether they are face shields, N95 face masks, disposable gowns, shoe covers, goggles, and boots, until they are no longer usable. While we ramp up local production of these organs, it is imperative that while we ramp up procurement of other items which we must procure, we must have rational use of those already in service. And this should include education about appropriate use, disinfection where possible, substitution where advisable. Measures should also be put in place to reduce theft and personalization of these items by the officers in charge, including checks and balances. Lastly, it has become imperative that some procedures would require the use of N95 face masks and respirators for their deployment. These procedures have an increased risk from droplets and aerosols from the aerosol generation that occurs there, whether from the procedures or from the activities. These procedures practically cover the whole breadth of clinical departments in the hospital. Our suggestion, our recommendation is that the cost of this should be inbuilt into the patient's bill or spread thinly across patients in those services to pay for this increased cost in rendering services in those areas. This will ensure that we are able to get returns to have continuous supply and replenishment for the N95 masks, and the same for the face shields. Otherwise, we will soon run out of being able to continue to provide services. While we are also, of course, asking for donors to come to our aid, including the government. Thank you for listening. I want to especially acknowledge all members of the team and our engineering department, the Linen Services Unit, and all the courageous and lovely heroes who are working assiduously at the front line in providing needed services for the community at tremendous personal strain and with great ingenuity. I want to also express my appreciation to the Chief Medical Director, Professor Darlington Obaseki, and the management team for their dedication, creativity, and resourcefulness that has culminated in ensuring that services is still ongoing in the hospital. God bless you all. I'll just run through a gallery of some of the things that we have done in the hospital. Those are the UV lights, chambers, and the mobile unit. That's the laundry and the isolation areas. This is the new isolation ward, the revamped isolation, and the old one at the bottom part. And then these are what some people would call the new normal in our A&E in presentation. That's our first patient that was discharged from my old isolation. This is the visit by the Edo State Governor to our facility and the Director General of the NCDC. And this is the signing of MOU with Professor Okonofa, Director of SIRI, and the Health Minister when he came on a visit, and the Deputy Governor. Thank you very much.
Wow. I wish all of us, you can hear everybody clapping. Dr. Kubo, like I said earlier, one of the greatest strengths that we have is human resources, high-level human resources. Professor Stanley Kubo, I'm very grateful for that wonderful presentation, running through the whole gamut of all we've been doing in UBTH. Thank you so much. I don't know, ICT, whether the results of the last question poll is ready. If it's not, at this stage, I'll call on, before we take some of the questions, I don't know who have been collecting the questions, call on Tochi. Tochi, please, you have 5 minutes if you don't mind, just a good message or one or two comments Tochi Okwo, represent the DG of NCDC. Then we also the chairman of my board, Chief Adewolu Adedoja, is on the call. We are very grateful, sir. We will find a way. ICT, please find a way to let him speak later on. Give you some time while we round up. ICT, please put chairman of the board, Chief Adewolu Adedoja, on the call as a panelist while we listen to Tochi. Tochi, please.
Thank you, Professor Obaseki, and your excellent team. First of all, let me bring the goodwill and the greetings of the Director General of the Nigeria Center for Disease Control, Dr. Chikwe Ihekwazu. He specifically stated that I must extend this goodwill and tell you that NCDC is very happy with the University of Benin Teaching Hospital, and we are very happy with the collaboration and the teamwork that is existing between the two institutions. What has become obvious and has been stated here is that COVID-19 is not a sprint, it is a marathon. And I love the quotation from Winston Churchill, never let a good crisis go to waste. And to that, I will add, when life throws you lemon, please make sure you make sweet lemonade out of it. Everything that has been said here is really what we should be doing. COVID-19 is novel. And by novel, it means that for us as Nigeria, even though we are resource poor, in quote, we are encountering it the same time that every part of the world is also encountering it. What that then means is that everybody must look inwards and find out what the resources are in-house and make use of that resource. And as we move forward into community transmission, what that then means is that we can no longer shut our doors to the provision of healthcare, even if that has been done. And it is very obvious that University of Benin Teaching Hospital never shut its doors. It could be that strategically you may have repurposed, redirected, or shifted some tasks. But one thing that is obvious here is that your doors have remained open. And one thing is clear, as healthcare workers, we have always been and we remain in the business of providing healthcare. And you have so excellently demonstrated that. A few statistics I'll share just from the presentation that was made there. The healthcare worker infection, the slide 16 and 17, when the infection prevention and control and team made their presentation. It is truly unfortunate that we have healthcare worker infections because healthcare workers are truly the diamond of this time. Healthcare workers have always been. It is just now that society is beginning to realize how valuable that we are. But when I look at the numbers, I'll let you know that you should be encouraged because I look at a number of contacts tested of 136, and from what I see here, if I got it right, 13 doctors positive, 4 nurses, and 3 of the other one. What it clearly shows is that your standard precautions and all the other IPC measures you put in place, they are truly working. So please continue to implement them. Continue to learn the lessons there is to learn, the lesson there is to learn at every opportunity. But with these figures, which until we even do genetic sequencing, we can't even tell if it came from community or if it was nosocomially transmitted. So please be encouraged, continue to do the surveillance. And to that, I'll add one more thing. If you could also factor in this screening of inpatients, just to make sure that you're completing the picture with respect to surveillance. And because I have only 5 more minutes, I'll straight away go to what we at the Nigeria Center for Disease Control will be hoping to continue to work with University of Benin Teaching Hospital with respect to infection prevention and control. And one of them is that we have a program which we call the Turn Nigeria Orange Network. And what that basically is that we plan to make sure that every tertiary facility in this country has meets the WHO core components for infection prevention and control. And UBTH is one of the facilities we have selected to be in what we call the Orange Network. And this Orange Network is a network of 32 tertiary health facilities in this country who will be supported to become centers of excellence for infection prevention and control. What that means is that work together to achieve the 8 WHO core components, at least to achieve the minimum standards for minimum requirements for that. And one key element for becoming part of the Orange Network is management support, political will from management, and that is not disputed today. From everything we have heard and seen, management support is not lacking. The second one is that we have a program we are doing in collaboration with our colleagues from the Robert Koch Institute to address issues around behavioral change. And to that effect, we have developed this package, this approach that we have called participatory approach in learning in systems. We've been piloting it and working on it over the last 18 months. And in about 3 weeks' time, we will be deploying our trainers who are skilled in using the participatory and systemic view to work with your institutions, IPC focal persons, and the people we'll call the change agents to begin to address some of these challenges around behavioral change. So that's one more thing we'll be bringing your way as in support. And then finally, we will be working with your IPC team, and that will be the IPC program, to begin to look for how to bring access to infection prevention and control trainings, opportunities for the IPC personnel, meaning people to become certified in infection prevention and control as practitioners, and also to broaden it for frontline healthcare worker infection prevention and control. That is where I'll stop, but I once more reiterate that please, you people are doing so well from what I've learned here, what I've heard here. It is a huge challenge, and but please be encouraged and know that at the end of the day, everybody will be counted for what they did or didn't do at a time of national crisis. And once more, I bring back to you again the extreme pleasure of the Director General of the Nigeria Center for Disease Control, Dr. Chikwe Ihekwazu. He's truly pleased with the work that University of Benin Teaching Hospital is doing. Thank you very much.
Thank you, Dr. Okwa Tochi. We are very grateful, and please do extend our appreciation and gratitude to the DG NCDC. We know how busy he is. We know the great work you guys are doing there. Fantastic professional job we are doing, and all of us in Benin, not just UBTH in Edo State, we appreciate him a lot, and please convey our appreciation. Thank you. ICT, please. We have pictures. We had about 400 attendees at this webinar, but beyond that, we set up viewing centers across the hospital, about I'm sure more than 10 viewing centers, and we have pictures of them right now. ICT, are we ready for that? Please. And to show, yes, okay. I don't have control over this ICT. Move it along. The pictures of the, yeah, thank you. So these are the pictures of our staff viewing this live. So all together, I'm sure we'll probably get up to 700 attendees. Look at different departments, everybody sitting down to watch by using their face masks, maintaining social distancing. These are VIP lounge. Yes, these are Abakenswa Hall. VIP lounge again. Go on, just go on there. Exactly. So, of course, we do realize that not everybody can have access to the internet and have computers. So we made this arrangement across the hospital. Different departments did this, and we are very elated at this. We are sorry we cannot take everybody questions because we have to, everything must be time bound. This is right below my office. This is the seminar room downstairs. We have the staff, somebody snapped me, I didn't even know when. We have a staff strength of about, my secretary, of about 4,000. So it's very gratifying that all these efforts, because if you put up a show and nobody shows up, it can be discouraging. So I want to thank the staff, the whole staff of UBTH. We appreciate this. I don't know, ICT has enough. I know you have millions of it. Please, we appreciate this. I don't know whether the exit poll, the results of the exit poll is ready. ICT, you can talk. Don't be scared of talking.
It's ready, sir. I'm about to share.
Okay, please, thank you. So we can see what, yeah. Whoa, I think we should all clap for ourselves. We also want, one of the things we are committed to in this management team is self-improvement, continuous learning. We always want to do things better. We are ready to go the extra mile. So we look at ourselves, what we do at every time, and see how we can do it better next time. And better informed of management response to COVID-19. 95%, whopping 95% said yes, they are now better informed. So this makes it all the effort worth it. We are grateful for that. 2% said no, they are not. Quite left, 4% said they are not sure. The second question is, the COVID-19 response in UBTH is optimal, of course, 64%. Again, it is a pass mark for us. Says it's yes, 15% said no, while 23% are not too sure. Of course, this does not, I mean, it's not, doesn't mean that we know that we cannot even discover ourselves while we are still fighting this pandemic. It's just the beginning. Dr. Greg just said now that our peak has been moved for that 2 weeks. We just pray that it doesn't move by another 2 weeks after we get to that 2 weeks time. Move down, please, ICT. I'm now more confident in handling issues related to COVID-19 in the hospital. The third question, ICT, please. Scroll down. Saibobo.
You can scroll down. I think you have control over it.
Oh, okay. Sorry, I didn't know that. Thank you. I'm now more confident in handling issues related to COVID-19 in the hospital. 74% said true, while 7% false, and 21% are not sure. This group of people that are not sure. I feel safer carrying out my routine duties in the hospital. 63% said true, 40% false, 24% are not sure. Now, what the major lesson we're taking from all this is that we want to look at these numbers. We're going to work harder to drive these numbers forward, because carrying the hospital along is key to us. Carrying the staff along is key to what we are doing. So thank you, ICT. You can stop sharing now. We have few questions. Dr. Greg, I don't know whether you're writing the questions down. That can take 5 questions maximum.
Yes, sir. Yes, sir.
Not just your question, I mean, for different persons.
Yes, sir. I took some questions down for different persons, sir.
Okay, we will answer the questions. It should be more than 10 minutes. Sorry if I'm rude. If I feel you are talking too much, I answer your question, I will cut in, or we need to stick to time. We have to work. Our patients are waiting for us. All right, Greg, we need to see your face.
Thank you, sir.
All right.
Thank you, everyone. The first question goes to Dr. Benson Okwara. The question is, the 36 mortalities, where are these bodies kept?
Dr. Okwara, are you there?
I'm here, sir.
Jam question.
Very, very interesting question, really. Okay, let me answer it this way. I can speak to, first of all, those that died in our care in the isolation. Okay, I'll start with that. We've had 8 deaths from the isolation ward, and those patients, the morticians who are on top of the job, of course, because it's isolation, they are well prepared to come and take the body. The state has been grateful enough to provide some body bags for us, but not enough. So they put these bodies in the body bag and move them to the mortuary. Now, as I said earlier, most of the other mortalities actually occurred before their results were available. Okay? So I may not be able to answer to what happens to their bodies, but I can also tell you categorically that in taking a look at the case notes, many of these persons actually take their loved ones, the bodies of their loved ones, away, you know, because they signed that they were taking it away and that they were not going to accept death certificate, and they will take responsibility for anything that happens. So it's difficult to really give an example, but I can speak to those that died in our care in isolation ward.
Dr. Brett, I think that the person that should have answered that question is Dr. Sorry, head of IPC. I should have called, sorry, Bodo, please answer that question.
Thank you, sir. So what happens is that any suspected or confirmed case of COVID-19 in the hospital, upon death, that body is flagged. We have tags that we flag, red tags that are written hazardous. And as soon as we have a rapport with the anatomic pathology department of this hospital, and we also have rapport with the state epidemiologist. And so once this body gets to the anatomic pathologic department of the hospital, the bodies are placed in body bags and proper IPC measures are carried out there. Bags and the proper IPC measures are taken, the body is sprayed with hypochlorate and the rest, and sealed in these body bags up until the family is ready to bury. Now, the body must be buried in accordance with the state laws, and the IPC, state IPC must be aware, and they take charge of the burial. So they must come, and it is upon citing the state team that we allow for such bodies to leave, because as soon as they come for final burial, the state team are the ones that take charge. Thank you, sir.
All right, thank you. Great.
The other question is almost a combination of 15 different questions, but the headline is, how are we handling the psychosocial dimension, and why is the psychologist and the physiotherapist not involved in the team?
Oh, okay. I think I would call the CMAC. CMAC, are you with us? Are you on the call? I didn't see you with Ben.
Yes, we're trying to maintain social distance.
Okay, very good. Please, can you take that question, or you want Ben to, or somebody else?
Okay, can you just repeat it again, because I didn't quite hear it.
Thank you, sir. The psychosocial dimension of COVID-19.
Okay. Yes.
How are we handling it, and why is the psychologist and the physiotherapist not involved in the incident team?
Okay, thank you for that question. We are actually handling the psychosocial aspects. We have a very good team, the HOD of Medical Social Works and Dr. Kolesho, a clinical psychologist. They see all patients who are admitted in the isolation ward. They either see them physically or they use phone contacts or whatever, and they maintain follow-up. And also, any staff who is exposed that feels they need care, they can get access to them. Regarding the physiotherapist, they're taken in only as an ad hoc basis, if necessary. For now, definitely as we upscale our care of the patients, they will be made part of the group. But for now, they have not been made a complete, permanent part of the group.
All right, thank you, Simak. Greg,
Thank you, sir.
3 more questions.
Okay, still to the CMAC, 2 questions to the CMAC from the pool.
No, I will be directing to Huto, so I won't make the first mistake.
Okay, thank you, sir. So the question is the treatment totally free in UBTH, and what is the definition of medical staff?
Okay, like I said, see, that's my question. Right now, yes, all COVID patients are treated free. All testing is done free, because I saw some of the questions. And but for how long can sustain that, I don't know. We have run out of funds. So very soon, we don't know how. We are discussing with the state. We've not got any reimbursement thus far for all the work we are doing, all the patients we are treating here, and tests we are doing. But the second question, which is, what is the definition of medical staff? That I saw it as a recurring decimal amongst so many of the questions. It's not a UBTH thing, it's the Federal Ministry of Health thing. They sent a template for remuneration of hazard allowance and inducement allowance, and they categorize the staff working in all the hospitals as health and non-health. We didn't know what that meant, but I think eventually it was clarified to mean clinical staff and non-clinical staff. Clinical staff are those doctors, nurses, pharmacists, physiotherapists, medical lab scientists, occupational therapists that have direct contact with patients. Non-clinical staff include administrative staff, accounts, procurement, name them. So that's how it was defined. I think that's what the ministry said we should use. Thank you. Next question, please.
Thank you. The next question has to do with reinfection and immunity of COVID-19 patient cases.
That's your question. Now.
Yes, sir. And I quickly want to speak to it, sir. From what we have, the evidence with respect to immunity is actually still sketchy. But what is known is that because majority of the cases are mild, so mounting the developing immunity based on mild infection compared to based on severe infection differs. Severe infection actually have a higher mounting of immunity compared to the mild cases. But COVID-19 has shown that what the epidemiology shows is majority is actually mild and sometimes asymptomatic. And also, even after they have been infected and recovered, we are not too sure how long that immunity may stay. Evidence have shown from tests done on antibodies and all that they could stay for some few weeks. And when compared to other families in coronavirus cases, they also be shown that they can stay for a few weeks, but there is no evidence, landmark evidence to show that there is immunity, which simply means there could be reinfection. So it is still evolving and evidence is still sketchy at this time. So we still have to maintain social distancing before, during, and after infection. Thank you.
Okay, but okay, go on. But I think I read a report this morning, or this morning yesterday, somebody posted that right now, apart from antibody immunity, humoral immunity, that there's now known to be a T-cell response, which also provides some degree of immunity. But like you said, we are still learning a lot about the virus. Please go on.
Yes. So the next question is 1 or 2 meters. Which one is recommended? It seems to be conflicting from the presentation.
Yes.
So I'll quickly respond to that myself. What is advised and published by the National CDC is 2 meters. But at the same time, if you read the CDC document, you notice quickly that they put in brackets 5 feet. But I just want to quickly correct that 2 meters does not correspond to 5 feet. 2 meters is actually 6 feet. I'm sure we are being polite with 6 feet, which does not really sound well in our cultural setting. So it is reflecting 5 feet. But it's actually 2 meters that the NCDC has encouraged, and not necessarily not 1 meter. However, I must also say that in addition to social distancing of 2 meters, it is not entirely protective, because you still need to apply the face mask and observe other precautions. Because if you look at the scientific underlining the dynamics of droplets and the biomathematical modeling of droplets in spread of the disease, vis-a-vis ventilation and indoor air dynamics, you just realize quickly that 2 meters may not be the real deal. Sometimes it can go as far as 8 meters. So that's why, in addition to social distancing of 2 meters, face mask is preached, hand washing is preached also.
Okay, thank you. One more question. This should be the last one. We need to round up.
So the last question here is, well, I just think we need to emphasize this, because 2 comments came from, we don't believe COVID-19 is true. And this is a comment on the platform. So I think we should also speak to it, sir. Is it not malaria? We don't believe it is true.
Okay, I saw it. Is it not malaria? Who is best suited to answer this? Greg, you go ahead.
Okay, thank you, sir. I just want to beg the consciousness and our intellectual capacity to please again, evidence have shown, scientific evidence. I mean, there are doctors in the front line. We have them in UBTH. it has shown, I mean, we know how to define diseases. We know how to say this is malaria and this is fever from malaria and fever for any other condition. We can make differential diagnosis. All over the globe, it is a consensus. COVID-19 is a new disease, and we know how to pick it in terms of the agent or the virus causing it, and in terms of the symptoms it presents with. Even we can characterize the type of fever due to COVID-19. So it's malaria, yes, is with us, it's endemic, but fever due to COVID-19 can actually be differentiated, and other laboratory testing can confirm it. It's a new disease, and we are working with it right now, and we are looking for how to provide cure and vaccines. Thank you.
To add to that, for any doubting Thomas, what I will advise, because I mean all this theory, all this grammar that Greg is speaking, please, do you mind visiting our isolation center? Let's show you that it is real, and let's why you can speak to. If you still have doubt, you can speak to one or two of our patients. Of course, well protected. We'll kit you up so you can see some of our patients. So many patients have gone through this. We've lost lives, so it shouldn't be trivialized. It is real. It is with us. People are dying from it. So please, I think that's enough on that. Greg, I think that's the last question.
Thank you, sir.
The other thing is there are two persons that want to speak before we close. The WHO representative in Edo State. Please, madam, you have 5 minutes to make your comment. Mrs. Faith Ireye, she has been fantastic, wonderful support for UBTH and the state response. Madam Faith, please. And before the last person that will speak will be my board chairman before we round up.
Yeah, good afternoon, everybody. I think I'm so happy to be part of this, to have listened to all this wonderful presentation. And one thing I want to say that COVID-19 made me realize in Edo State, I've been here for 12 years, but I didn't know we have such superb, I mean, intelligent people, very intelligent people in UBTH. COVID-19 exposed a lot of things. I want to say a big thank you. What I want to say here, other things, I will not waste time saying them here. I will call the individuals. UBTH, since the inception of this pandemic, have proved themselves to be center of excellence. I'm not just talking because people are here. I'm really proud of you people. With all the technical support provided by you people, with the able leadership of your CMD. I mean, in fact, I'm being blown away each day, every time, anytime I have contact with anybody from UBTH during this pandemic. People have really proved yourself. And I must thank you, Professor Darlington Obaseki, you know, which is your leadership style. Please keep it. I envy you. Please keep it. Because people may be technically sound, but they will just be covered there. I've been coming to UBTH for some time. Please and please. In fact, as I'm talking, I'm close to tears. A lot have come from UBTH, and I'm very grateful to all of you. Thank you very much. And I hope that after this pandemic, and even during this pandemic, please, from the data, we all keep talking about the elderly, about the vulnerable people that are dying. Me, the WHO, we are ready to partner with you, no matter how small. WHO have contributed at the nationally, but you know, they feel that from that side, everything will be distributed to state. But I think in this aspect, I really want to work with you people. And something came out very clearly from the CMD presentation. All these materials that you are locally producing, I put it there. Can we upscale this production so that the state can procure from you for their own facilities? Because this is fantastic. We have these local materials here. Why are we going to be going everywhere sourcing for these things? And sometimes it's they are out of stock. So once more, I want to say a big thank you to all of you. We are proud of you. And my madam is still talking. I mean, the OIC is still talking to tomorrow about UBTH after that visit. Please keep working together. And please, CMD, keep stitching everybody together there. Keep bringing out our heroes. Thank you very much.
Thank you, Mrs. Faith Ireye. I can say one thing about this woman. Since the pandemic entered Edo State, the virus entered Edo State, we have been together with the state response. WHO support in Edo State has been critical in what we have been doing in Edo State. Madam, we are very, on behalf of all Edo State, we are not from Edo State, I think you're from Delta, but the way you've supported us in this state, the people of this state will remember you, will love you, will keep praying that you live long and remain in good health. Thank you, madam. And all your support, including to UBTH also, we also appreciate that. ICT, please, there's somebody I want to put on the call. I will call on my board chairman now. Chief, Baba, who is Baba there? Baba should be on the call. Our board chairman, who has, I mentioned it in my presentation, the management board of UBTH has been extremely supportive. And this man, who is an octogenarian, who has been the backbone of my administration. Please, Baba, can we, that's him. Can see
okay.
Baba.
Hello. Prof, how are you?
I'm very fine, sir.
Well done.
Yes,
I have listened to you attentively from beginning to the end, and I'm very, very happy and pleased because you have not disappointed me, and you have not disappointed the board.
Thank you, Baba.
First and foremost, let me say to the people that have come there, it's not by accident, it is by design that UBTH is the longest, the oldest teaching hospital in South Nigeria. And he has always been the head and the leader of all things. What you have done this day, you have justified the leadership role that you are to play in the health service in Nigeria. And I want to assure you, we agree with so far all you have done. I have listened to all the comments and the lecture, and particularly the Orange Committee that you say we are partnership with. We will give them full cooperation and understanding. Hello? Are you with me?
Baba, we are
hello?
Baba, we are hearing you.
Okay. Thank you. Thank you. And also, I want to say that I'm very, very happy with the way all the staff have been working hard without anybody shifting the thing. And now you have been using the IGR to do this thing. I'm happy the WHO representative is now there with you. The last time I was in Benin, when the Honorable Minister came, we were together. And I told her that WHO owe us a lot to do in University of Benin Teaching Hospital, because I remember when the late Professor Adeoye Lambo, the first African Deputy Director General WHO, he made a remark that University of Benin Teaching Hospital deserved to be given better attention because it was in Midwest that the first hospital health management board started, and WHO had to send some people to come and see how the management board were running. Now UBTH is there. I will want to have full support of everybody. I want to thank the CMD, the CMAC, and all the professors and all the technical, the IT people. You have all done very well. I appreciate you. And also, I want to let the CMD and everybody know that when they said who are the medical team and things, healthcare delivery is a teamwork. Everybody has to participate. Everybody has an interest to put. And I'm very, very happy to inform you that I made contact with the Honorable Minister of Health and, of course, the director and the thing in the allocation of funds. The percentage of which they are saying that some people are qualified and not qualified, we are looking into that, because some of us believe that even in the healthcare delivery, we are all important and we are all core. So it has to be fair to all. You have to, and I'm so happy that everybody, when they come to UBTH, they know they can get the best. And all I want to say, they must give assurance to people that coronavirus is real. And therefore, we need some preventive, we need some people to be reassured that we should not be careless. I will appeal to all the doctors, all nurses, all health workers, all the scientists. At the end of each day, when you get home, fill your your bath and have an inhale of hot drink or thing inside, because coronavirus is not like cancer, which is endemic. It takes 14 days for it to cover. If you can try to use within those 14 days to warm down your blood pressure and blood thing, you will have no problem. So I want to congratulate you. I also want to make the last request.
Yes,
With this thing they have done, let us have a paper, the hard copy, so that we can also advise our fellow teaching hospitals. Some of my chairmen have heard about it, and they are making effort to say, because what you have done today is very, very educative, very illuminating, and you have all done very well. God bless you, and well done.
Thank you, Baba. The backbone of this administration, I cannot tell you people how much he has supported me personally. Like he has been a father to me. Baba Bashorun, may you continue to live long in good health and soundness of mind.
Thank you.
Thank you. Please, before we round up, I will crave your indulgence to allow one more person speak. Ms. Uzo Ukoma is a consultant on health to Edo State government. Uzo, are you on the call? Yes, Uzo.
Yes, sir, I'm on the call, sir.
Yes, please, go on.
Good afternoon, ladies and gentlemen. Good afternoon, the team and all the speakers and panelists. I must commend very specially. I had planned to be silenced through this call, but the kind of impact the last, say, 2 hours has had on me has compelled me to speak. Professor Obaseki, we have worked very closely, probably in the last 1 year, most especially in the last 3 months. Your team, most especially Dr. Esohe, Dr. Okobo, Dr. Okwara, have worked with the Edo State government in implementing probably one of the best pandemic response I have seen since I started my short career. But most importantly, it is the tenacity to keep going that I must commend the entire team. UBTH, from day one, we walked into UBTH and we identified very quickly that UBTH was an organization that definitely was the best prepared to assist the Edo State government and the people of Edo State to respond to a pandemic of this size. As a result, we advised the government to ensure that all hands were on deck at UBTH to support the team and to enable UBTH support Edo State government. It was very important for that to happen. And I must say at this point in time that we are super proud of your work. It will go down in history what you have done, not just to UBTH and Edo State, but to Nigeria indeed and West Africa, if we're going to look at the region. Some of the energy that has gone down in the last 90 to 120 days from your team, I have never seen it. And I praise you, I commend you, I pray that God blesses you. And I mean the entire team, the entire response from UBTH. When push came to shove, you guys stood tall and made sure you stayed true to your calling. You've been professional, you've been effective, you've been helpful, you've been considerate, you've been loving to the people of Edo State, and I must appreciate that. Thank you very much, Prof. and team. Thank you.
Thank you so much, Uzo. Don't get us emotional here, please. Thank you so much. Uzo Okoma is a special consultant to the state governor and state government on health, and she has been very, very instrumental in many of the things that we've done. She has been a bridge between us and the government of the state and the State Ministry of Health. So Uzo, thank you. Keep working. You and Madam Faith Ray, That'd be wonderful. So we need to round up now. Let me round up by thanking everybody. Let me start by thanking my board chairman, who I'm pleasantly surprised that he showed up physically. Baba, you're always surprising us. We appreciate you. Thank you.
No problem. No problem.
The DG of NCDC, Dr. Chikwe, I know you would have been here personally. We are very, very grateful. The team here, the person, I want to thank everybody, all my members of my team, but there's somebody that is somewhere very far off in Finland. Is suffering cold. He has been suffering loneliness for months. Dr. Greg Okobo, I don't know, he's a student. Baba, we sponsored him to Finland to do his PhD. And I don't know whether his PhD is still doing, but he's there with us every time we call on him. He has been helping the state government producing models for projection of projecting the pandemic. In conjunction with Atlanta CDC, he has contacts there. Conjunction with his colleagues in Finland. These things have been given to us free of charge up till now. We have not asked for a kobo from him. He has not asked for a kobo from us. And if we've had to, we cannot put naira and kobo to some of these things that we are doing. But everybody, UBTH, the staff, my management team, the CMAC, Professor Korea behind the scene. She's always behind the scene. Professor Adeleye, Dr. Stanley Okubo, and Dr. Mokogu, everybody, we are a team of the DDNS. We are very grateful for all the support we've received from the hospital. And we want to say that this is part 1. We have another 5 listed where we talk about diagnosis, we talk about screening, triaging, and monitoring. There are so many other areas that we have not talked about our response, and the research arm of it. We are currently, we have about 33 papers, articles that we are lined up for publication, out of which we have published 3, another 4 will soon go out for publication. So before the end of August, we should have published about 20 articles on our response, because our belief is that whatever we are doing, it should be documented so that others can learn, other institutions across the country can learn, and others coming up. This will not be the last pandemic anyway, and other viral infections will come up, so that we'll have it documented. We'll be better prepared in Nigeria to handle this. I want to also thank the CMDs and MDs of other hospitals, private and government hospitals, CMD of Solu Psychiatric Hospital, Agbonile, I don't know whether he was on the call, Benin Medical Care, Edo Specialist Hospital, Iwa Specialty Teaching Hospital. We decided to open up this discussion, this webinar to everybody because we felt we can all learn, and I hope we have learned from it. I thank all of you. We will do another one maybe in 2 weeks' time, but we need to breathe. We actually plan for next week, but we need to breathe. It's a lot of work that goes into all this, a lot of work. I thank you and I appreciate all of you. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, everybody.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you very much, sir.
Thank you, Prof. and team.
Greg, don't die of colo.
Yes, mommy, I will. Thank you, ma.
Well done for the great job.
Greg, you hurry and come back.
I will. I'll be around soon.
Uza.
Ma. God bless you. Well done, ma. God bless you. Thank you.
And bless you too.
Thank you, Uza. Good to see you.
Bye. Good to see you. Bye.